Okay, then we'll start the lecture today. So, hello. So, I'm Dr. Dasit. I'm currently working in NHSL as a second year general surgery registrar. So today we are going to discuss a very important topic in your ERPM exam. It's called the basics of trauma. This is very important because this could be questioned you in the MCQ and as well as the SBA, mostly in the SBA, and this can come to you in the part C also, where you are sitting for the emergency viva with for surgery track. In there also, this can come for you. So this is a very important topic, but this is a very simple. Sorry. So this is even though it is very important topic, this is very simple to understand. This just needs some little bit of basic medical knowledge and common sense. If you have those two, understanding trauma is almost next to nothing. So let's deep into the lecture. Okay. So in this lecture today, we are going to discuss a scenario, just case scenario, and then we discuss how the process takes part from the accident up to the hospital setting, and how we manage it at the hospital setting, and how we assess the patient at the hospital setting. Okay. So imagine this is the situation. So there's two buses traveling in opposite directions and collided face to face in Kerala. And the police and the emergency medical team has responded the source area, and the incident, like 4 people has died, including the 2 drivers, and around 45 people are injured. And the Kagal hospital, now you are the house officer in Kagal DGH, and you are being informed by the police and the ETU that there's a situation like this, and the patients are going to come in few hours time. So what will be happening at the hospital setting as well as at the site of the injury. So we'll first look at what will happen at the site of the accident. So so first of all, before that, we have to talk about what is triage. Triage is a system where we sort out casualties. Now imagine now I said there are around 45 people injured. So there's a limit of how many people we can treat at one setting in our hospital setting. That is called either multiple casualty or mass casualty. So when you talk about multiple casualty, that is when the injured number of people does not exceed the capacity of the hospital or the healthcare sector that is treating the patient. But in mass casualty, it's the opposite. There are a lot of patients, and at that time the service provider, healthcare service provider is overwhelmed, so they can't handle all of these patients. So in these two situations, how we approach patients are different. For example, in multiple casualties, there's a number of casualties, but still the hospital can handle that amount of patient. So in that case, our aim is to treat the patients with first of all, treat the patients with the most life-threatening injuries. That is our priority. If it's a multiple casualty, imagine there's a situation where 3 or 4 people are injured. In that case, we prioritize the patient with the life-threatening injuries. But in mass casualties, for example, like the situation I gave you earlier, 45 injured, 45 patients. In that case, the hospital is overwhelmed and overburdened. So the hospital can't handle all of them. So what will happen? So the aim is to do the greatest good to the greatest number of casualties. So our aim is to treat the patients with who have the most chance of surviving. Okay. So that is what an triage is. Okay. Okay. So the triage is divided into 2 parts. There's a triage happening in the field and the triage happening at the hospital setting. So first of all, we'll look at what will happen at the triage in the field. This triage in the field will be not done by medical professionals like doctors. It will be mostly done by the police and as well as the EMT. For example, the suicide area personnel, those guys. So first of all, what happens is you identify the alive patient, the patients who are alive, and move them into a safe site from the injury. Now, there's two buses collided. There will be petroleum leaking. There will be a lot of metal pieces lying around. So it's not a safe environment for the alive people. So our first priority is to get the alive patients to a safe area and then assess these patients. Even though they are alive, they might not be conscious. So assess the response to verbal command. When we assess a patient, when we talk to a patient, and if the patient can respond to us, that gives us a lot of indication. That means the patient can breathe, patient can, there's airway, that airway is patent, the patient GCS is all right, so his brain perfusion is all right, no head injury at that moment. So it gives us a lot of information. So we first of all check the response to a verbal command. For example, we call by, can you hear me? Can you hear me? If he says yes, yes. And then we check the presence of breathing. We just check whether there's respiratory movements, whether we can feel breath coming out of the nostrils and mouth. And then we assess if there's any uncontrolled bleeding in these patients. And if so, we need to stop it. So if we identify these, we can identify all the life-threatening conditions by assessing these 3 points at a setting in the field. Okay, and then we can attend to those people as early as possible, and immediately stabilize as much as possible in the peripheral setting and transfer the patient to the hospital. So as I said, the emphasis is to keep the airway maintenance. You insert a oropharyngeal tube and apply face mask oxygen. If there's a massive bleeding, control the bleeding, immobilize the patient, and transfer. So this is something that is published in the ATLS. What they recommend for uncontrolled bleeding is first apply pressure with just the hand. And once the dressings and go soaps are available, apply with dressing and press on it. Keep the dressing, keep the pressure. Apply pressure. And then if a tourniquet is available, apply the tourniquet. And then transfer the patient to the nearest hospital. So that is what's happening at the site of the accident. So that is the triage done at the field. You understood that concept? When a trauma happens and there's a mass casualty, we try to identify the patients who are alive and then assess them according to the life-threatening conditions. And then, depending on the priority, we transfer them to the in the order to the hospital. Okay. Now we have covered the what will happen in the site of the accident. Now what will happen at the hospital? Now we have been informed by the EMT and the police, as there's going to be mass casualty and patients are going to come in a lot of numbers. So what is going to happen? So once the notice is there, the emergency department utilize all the personnel. For example, they get down all the doctors, nurses, and because we need a lot of staff to cater all these patients, we need a lot of staff. So get the doctors, get the nurses, get the minor staffs, everybody. And then there should be a team lead appointed before the patients come to the hospital, because the team leader is responsible for the smooth flow of events, because he will be taking all the decisions. So there is no confusion between the team members, and the team leader also decides when and which hospitals the patient should be transferred. if they need higher center care. And he will be in charge of the, he will appoint a person who is the most senior doctor for the triage in the hospital. So there's a triage at the paper accident setting, and there's a triage at the hospital. So the team leader will appoint a doctor who will do the triage at the hospital. And this doctor should be one of the most senior people. He should have, that means more experienced person should be the triage, the officer doing the triage. Okay, that is what will happen at the hospital. And they will get down all the necessary equipments, and they will notify the theater, and all this will happen before the patients arrive to the hospital. Okay, now we will go to the triage of the hospital. So when the patients start coming to the hospital, we divide these patients into 5 categories, and we give them color coded tags: red, yellow, green, black, and expectant. There's no color code for expectant. So the red is urgent. So as we all know, red is bad. So red is urgent. They need immediate attention, and they need life-saving interventions. For example, a patient with tension pneumothorax, patient with cardiac tamponade. So those are they are life-threatening events. They need to be attended immediately. So they are in the red category. Then comes the yellow. That means delayed category. They need treatment, but it's not urgent. They can wait for some time. For example, they can wait 30 to 40 minutes, 30 to 1 hour, 30 minutes to 1 hour. So the patients in the red category are sorted out. They can wait till then. And during that time, if they escalate to the red, then they will be taken and treated accordingly. That's what yellow is. Okay. For example, tibial mid shaft open fracture. Yeah, so tibial shaft open fracture. So, but the patient can wait because it's not life-threatening. It may be limb-threatening, but not life-threatening. So that patient can wait until the red patients are sorted out. And then comes the minor or green. They need very minimal care, or sometimes they don't even need care, because there are some people in the bus who must have not have any injury. They are just in emotional shock. So those people will need only minimal treatment. So these people will be treated last. But again, for some mistake, we have misdiagnosed them, and they escalate into red. We should prioritize them also. Okay, and then come the black. Black is diseased patients. So that is out. And then the expectant category. In cases of mass casualty and patients not expecting to survive because of the very severe injury. For example, patient coming with severe trauma to head. The head is basically crushed and go to the hospital. Patient is still, you have a pulse, but you know this patient is not going to survive. So because of the severity of injury, you know that this patient is not going to survive. So even then, we prioritize the patients who are in the red category beyond this patient. So you got the idea? You understood what I said? So how this triage happens at the hospital? I hope yes. Okay. So, and then the trial should be done immediately, and it should take a very minimal time. And then the red patients are brought into a treatment area, and the advanced trauma life support. You need to know this term because this term will be encountering you during this ATLS will be during this lecture presentation. So ATLS will be initiated. Okay. So why this triage and everything is happening? Why do we prioritize these patients? So let's dive into that. It is because we need to minimize the golden hour. So what is the golden hour? So Imagine now the injury happens now. Just now the injury happens. This is time 0. Basically, just seconds before the injury is time 0. Okay. From that time onward, the time starts ticking. Okay. When the time, with the time, there are 3 peaks of death in trauma patients. That's the first peak, that's the second peak, and the third peak. So the first peak of deaths, almost responsible for the 50% of deaths in trauma, is within minutes of the injury, within the accident. For example, a laceration of the brainstem, high spinal cord injury, injury to the heart, injury to other large vessels like the aorta. The patient will bleed in minutes. In less than a minute, he will bleed out, and he will basically die within minutes at the site of the accident. So this is the first peak, and then comes the second peak. That is all. That second peak of deaths encompasses over 30% of the trauma deaths. Have around the deaths occur from minutes to few hours. So by this golden hour concept, our priority is to cater to this first peak and second peak patients, so we can prevent their deaths. First week, yes, the patient might die, but we can try. Even though we said the patient might die within minutes, we can still try to save that patient. So by this golden hour, we try to protect these 80% of these patients. Okay, to try to protect and save the lives of these 80% of these patients. And next comes the third peak. Third peak is usually around 20% of the trauma deaths. It comes in from days to weeks. It is usually the patient will be in critical care unit, and the cause of death will be sepsis, multi-organ failure, like that. So that peak of death we can't control with the golden hour. But with the golden hour, we can control this 80% of first peak and second peak patients with timely action. So that's why we take all these triage measurements, and we address the patient promptly, because we need to prevent this 80% of deaths. Did you understand this golden hour concept? I hope yes. If you have any doubt, just unmute the mic and ask. It's not a problem. Because sometimes even if you put a message, I might not see it, and I might see it later time. So if you have any doubt, just ask me, okay? If you are silent, I might think that you have understood and I will go forward, but if you have not understand, please ask. There's nothing to worry, all right? Okay. So that's the golden hour. Okay. All right. Okay. So after the triage, the patient will be taken into the emergency treatment room, and the ATLS will be initiated. So what is an ATLS? It is a sequential assessment of patient. Initially, if the patient identify and prioritize life-threatening conditions. Okay, so it is guided by a team. And one more thing to understand here, even we say this is a sequential event. For example, we know that ATLS, we prioritize the airway, breathing, circulation, and disability. But imagine there's a massive bleeding, and patient is unconscious also. We don't let the bleeding to go on while we attempt to settle the airway. It's a sequential. It's a even though it's sequential, all the systems are run through concurrently. That is why we need a lot of staff for this ATLS protocol. Okay. So while somebody is attending to the airway to to initially oxygenate, and once oxygenation is achieved, put a definitive airway control. Somebody will attend the massive bleeding and try to hold it with pressure. That's how it goes on. And somebody will be cannulating the patient and starting the fluids. It will be going concurrently, even though it is set sequentially. Sequentially, it is done concurrently. It is set sequentially because sometimes because the airway always takes priority than the circulation. That is because the time taken to die for patient to die from airway obstruction is much more less than a patient who die from intra-abdominal bleeding. And is the other, and vice versa. The patient to die from intra-abdominal bleeding takes less time than for the patient to die from an external extradural hematoma. For example, EDH, the patient will take hours to die, but intra-abdominal bleeding, the patient might take few minutes, around 20 to 30 minutes. So it takes more priority. That is why there's a sequence, but all of this should be assessed concurrently. Okay, let's go forward. So primary survey. So primary survey is very important, and we always know, we already know the sequence is initially airway, maintenance with cervical protection. We should always keep in our mind that the cervical spine could be damaged in trauma patient. So we handle the airway and we give airway maintenance while protecting the cervical spine. And then we go into breathing and ventilation. Then come the circulation and hemorrhage control. Then come the disability, which assess the neurological status also, and the exposure and the environment control. Okay. In the primary setting. So, did somebody ask something? Okay. So in primary survey, we start by asking the patient's name. We tap the patient and we ask, "Hello, mister, how are you? Are you all right?" If the patient can speak, that gives us a lot of assurance. If the patient can speak, that means his airway is patent. He can generate breath and he can exhale. That means the airway is patent and he can breathe. And the circulation is also somewhat, at least it is less than class 3 hemorrhagic shock. And disability, he has a GCS of higher GCS, because if the patient can just speak, the verbal component itself gives you good, verbal component comes as 5. And so the initial ABCD all can be, we can get a rough idea by just speaking to the patients. We can just speak into the by speaking to the patient. Okay. Okay. So when we talk about airway problems regarding airway, the airway obstruction could be partial or complete. There could be a foreign body obstructing, or there could be secretion that is partially obstructing, causing stridor. And it could be sudden or progressive. It can cause sudden obstruction, like for example, the tongue falling back, or it can progressively obstruct by developing laryngeal edema or respiratory tract edema. We can either sudden or progress. We should always keep our mind open for these possibilities. And we should be vigilant for airway compromises in patients with such as severe facial injuries, massive injury to the face with distorted facial features. Then we should have a suspicion. Maybe the airway is also compromised. Blunt or penetrating trauma to the neck, that could be injuring our trachea and the larynx. Burns around the face and neck, which can cause, even though there's no immediate obstruction, it can cause laryngeal edema, and it can cause obstruction of the airway. Unresponsive patients, GCS less than 8. We know beyond GCS less than 8, there's a high risk of tongue falling back and obstructing the airway. So we need to be vigilant for airway compromise. Patients with thoracic injuries and patients with gastric contents in the oropharynx, they might have already aspirated. So we should keep that in our mind. So how do you examine a patient for airway compromise? First of all, you look at the patient. I'm sorry for the typo. The look is not not typed in this presentation. It should be look, listen, and then feel. So we look at the patient. We look at the patient, how the patient is, whether the patient is gasping for air, how the patient is inhaling, is his abdominal breathing, whether there's nasal flaring, whether there are secretions around the mouth, whether there is trauma to the neck, massive hematomas in the neck. So we can look for these signs, nasal flaring, and then we listen. We listen for breathing sounds such as stridors, gurgling, voice hoarseness. We listen for them. So those sounds could alert us there's an impending obstruction of airway. In that case, we should attempt to intervene. We should intervene. And then we feel, look, listen, feel. We feel for expired air. We can just keep our finger at the nose level, and we can feel the expired air. And we can keep a small glass in front of the nostrils. So the expired air, there will be fogging of the glass. And we can feel the crepitus in the neck. If there's injury, penetrating injury to the trachea, there could be air leaking into the subcutaneous tissue, causing crepitus and hematomas in the neck. And we should feel for the trachea, whether it's midline in the neck. So that's how you assess a patient. You look at the patient, look for features of respiratory airway compromise, and then we listen to this patient, listen to the sounds, and we feel. Okay. So imagine now the patient is having stridor. You can see the nasal flaring. The patient is basically gasping, and your patient is disoriented, and there's a stridor. You can hear a clear stridor. What are you going to do? First of all, give the patient oxygen. Now there's already the oxygen going into the lungs or less. So we can supplement the patient by giving supplementary oxygen, high flow oxygen at more than at least 10 liters per minute should be administered. And then C-spine restriction should be done before attempting airway maneuvers, because we know C-spine could be damaged, and we didn't have any time to check the disability score because we are still at A. So we assume that there's an injury, and we do the C-spine restriction. It can be done by a lot of ways. For example, in the pre-hospital setting, it can be done by sandbags and blocks. But when you come to the hospital, we can do it with the Philadelphia cervical collar, which I will show you a photo of Philadelphia cervical collar in a few minutes. And imagine there's a collar, we can't intubate with that collar because we need to maneuver we do the airway maneuvers. So in that case, the collar can be opened up, and the neck can be, C-spine can be manually inline stabilized while intubation is done. These words might come in your MCQ. So it's worthwhile knowing these words, because sometimes these things can be asked in the MCQ. This manual inline stabilization, Philadelphia cervical collar, C-spine restriction, this can come in your MCQs as stems, different stems. So then why we administer oxygen, and then we suck out secretions if there are any, and then we do the airway maneuvers. So you must have heard about the triple maneuver: chin lift, jaw thrust, and neck nail. So we don't do the neck because of the neck tilt, because we don't do because of the risk of C-spine injury. We only do the chin lift and draw thrust of the triple maneuver. We don't do the neck tilt. Understood? Okay. We do the chin lift, draw thrust. I'll explain what chin lift and draw thrust in a few seconds. And then we do the bag and mask ventilation. We apply a ambu bag, connect it to the high flow oxygen, and we do the bag and mask ventilation with the temporary airway establishment. What is a temporary airway? We apply a oropharyngeal or nasopharyngeal airway, and we do bag and mask ventilation. Once the patient achieves adequate oxygenation, we attempt the definitive airway. So that is how you manage the airway. Initially, apply oxygen, cervical spine restriction, suck out secretion, then do the airway maneuvers, chin lift and draw thrust, do the bag and mask ventilation with the oxygen while applying a temporary airway. And once the oxygenation is achieved, go for the definitive airway. I will explain what is definitive airway, what is a temporary airway in few seconds. So this is the chin lift maneuver and the jaw thrust maneuver. So the chin lift and jaw thrust maneuver, we can, with these two, we can open up the airway. So that if the tongue is fallen back, we can open up the airway. So the oxygen that we are delivering to the patient can be adequately passed to the lungs. So you don't need to exactly know how to do the C-spine maneuver, airway maneuvers at the moment. So just for the time, for MCQ part, just knowing these names will be enough. The chin lift and draw thrust maneuvers. Just to say, the chin lift is where we are basically, as in the photo, we are basically lifting up the chin from the angle, from the mentus. And then for the jaw thrust, we are lifting the jaw up at the angle of the jaws. So these two maneuvers lift up the tongue and open up the airway. So these are temporary airways. This is a nasopharyngeal airway, and this is an oropharyngeal airway. So as you can see, nasopharyngeal is basically the airways from nostrils to pharynx, and the oropharynx is basically from the through the mouth. So the contraindications for nasopharyngeal airways when there is a cribriform plate injury, that is the roof of the nose is injured, you don't put nasopharyngeal airways, because that nasopharyngeal airway can straight away go to the cranial cavity. Because of that, we don't put in patients suspecting of cribriform plate injury. This might come as an MCQ, so it's worthwhile knowing. And the most common temporary airway that is used in our hospital setting is the oropharyngeal airway, because it's very readily available. Even I have not seen a nasopharyngeal airway. Anesthetists might have, but as a general surgeon, I have not seen. What we most often use is the oropharyngeal airway. Okay. So there are other airways also, such as laryngeal mask airway. So basically, this you can see in the photo, this rubber balloon sits over the glottis, and it provides ventilation to the larynx and trachea. So this is called laryngeal mask airway. And there are other airway methods also, which if you know the names, that will be enough. You don't need to know exactly how it works and all, such as intubating laryngeal mask. So basically, it's a laryngeal mask, but you can put a endotracheal tube through that laryngeal mask. So that is more advantageous. We can easily intubate the patient through this. And another one is laryngeal tube airway. You can basically see there's a you put the airway, and there's two bulbs, so balloons. So those two balloons inflate, and then the part where the holes of this airway is almost at the larynx. So that that the oxygen that we give can be passed to the airway. And this multi-lumen esophageal airway also there. If you just know the name, that's enough. You don't need to know how this works. And multi-lumen, that's how you apply it. Okay. So what is a definitive airway and what is a temporary airway? The definition of definitive airway is a tube placed in the trachea and cuffed. And the cuff is, and that means, and then I showed you that there's a cuff in these tubes. For example, in the endotracheal tube also, there's a cuff like that. And that cuff should be inflated below the vocal cords. That is what we call as definitive airway. And then we connect it to an oxygen enriched assisted ventilation. If there's no ventilation available, then we keep with the mask ventilation, bag ventilation, if there's no ventilator available at the moment. Okay. So our goal is to achieve at least 95% oxygen saturation. I know you all know what is oxygen saturation is. That this 95% comes because in values less than 95, the oxygen amount in the blood drastically reduces. If you remember from your physiology days, the oxygen dissociation curve, it basically goes like a bell, what do you call it? Like basically like this. So the 95 is at this point, but if beyond 95, the oxygen content in the blood drastically reduces. So because of that, our goal is to maintain at least 95% of oxygen saturation. All right. So our indications for definitive airway is, if the patient is unable to maintain the airway by temporary measures, then yes, we have to put a definitive airway. If there's apnea and inability to achieve adequate oxygenation, then yes, again. Head injury with GCS less than 8, there's a risk of tongue falling back. Again, an indication for definitive airway. And if there's a risk of aspiration, aspiration, then again, we should put a definitive airway, because the cough inflated beyond the vocal cords will prevent aspiration of gastric contents or blood that is ingested. So that is definitive airway. Temporary airway is when the airway is placed above the vocal cords. That this you need to know. This might be asked from you in the emergency viva, and most likely it won't be asked from you in the MCQs. But it's good to know what is a definitive airway and what is a temporary airway. So this is a endotracheal tube. You can see the bulb, and then there's a connector. There's a length indicator, and then there's at the end there's a bevel where the oxygen can come out, and there's a connector to the pilot balloon. So with that, we can inject air so that balloon can inflate at the end. So this is a endotracheal airway. Okay. This endotracheal airway also, there are two types. This could be done by orotracheal or nasotracheal. I myself have never seen a nasotracheal airway. I only have seen orotracheal endotracheal intubation. If you know that there's something called nasotracheal, that's enough. You don't need to know what it is for details. And we insert the orotracheal airway with the use of either an optical or a video laryngoscope. We visualize the larynx, we visualize the vocal cords, and then we under vision, we pass the endotracheal tube through the vocal cords and cuff below the vocal cords. Okay. And for this endotracheal intubation, we need the patient to be paralyzed. That means it is difficult for us to visualize the airway with the muscles being tense. So we need paralyzation. For that, we use midazolam and succinyl choline. This you don't need to know by names. It's just, you need to know this term called drug-assisted intubation. Drug-assisted intubation with the use of a laryngoscope. If you know that much, that is enough. Okay. So imagine now the medical officer has put an endotracheal intubation. So how do you know whether the tube is in the correct position? The tube could be in the trachea, it could be in the esophagus, and even if in the trachea, it could be, we have inserted too much, it could go and lodge in one of the bronchus. So how to confirm it? To confirm the oxygen, tube is in the trachea, we can do a capnogram. So basically, we check the expired air for carbon dioxide. If there is carbon dioxide, that means it is in the trachea, because carbon dioxide comes from the lung. There's no carbon dioxide come from the esophagus. So if we detect carbon dioxide in the capnogram, yes, it is in the trachea. And we check for bilateral equal breath sounds. If one side is not equal, then most probably the endotracheal tube has gone far into a bronchus. Okay, and we check for rumbling sounds in the epigastrium. If the endotracheal tube is in the esophagus and we are ventilating, we might see air, we might hear air going into the stomach, and we can hear the rumbling sounds in the epigastrium. And then once everything is settled, we can do an X-ray to confirm the location of the trachea, because the endotracheal tube, there is a radio opaque line, and this radio opaque line can be seen in the X-ray. So we can do an X-ray and see definitively, we can get definitive confirmation that this is in the trachea. That's how you check whether the endotracheal tube has been correctly placed. These things can be asked from you in the MCQ. Okay. So some patients, for some people, endotracheal intubation is easy. For some, it will be difficult. So if there's a difficulty, how do you assess the difficulty prior to attempting intubation? And if there's a difficulty, what would you do? Okay. Now I said earlier, there are two types of laryngoscopes, optical and as well as the video laryngoscope. The video laryngoscope gives us a better view, and we don't, and because of that, if the patient is, we expect the patient to have a difficult intubation, we might try the video laryngoscope. And video laryngoscope, being said, it's not readily available in our hospitals, but that this option is there. If it's difficult intubation, we can go for a video laryngoscope. And then, while attempting intubation, we can give a pressure for the thyroid cartilage. So the trachea is depressed. We can put a backwards, upwards, and right side pressure on the thyroid cartilage. So the vocal cords and can be better visualized through the optical laryngoscope. And then we can use the gum elastic boogie. So this is this gum elastic boogie. So it's basically a plastic piece of plastic rod with the curved end. So we can, under the guidance of laryngoscope, we can insert this smaller plastic bougie through the vocal cords into trachea. And since this is curved, when we try to take it out, we know that trachea has cartilage rings. When we take it out, this will rub against the cartilage, and we will feel that rubbing sound, like tuck, 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 tuck. We will feel it. And if we feel that, we know that we are in the trachea. If we don't feel that, that is most likely we are in the esophagus, because there's no cartilages in the esophagus. It just smoothly comes out. But if there's like that tuck, 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 tuck feeling, it will be in the trachea. So that is also an adjunct that we can use in difficult intubation. And if everything fails, then what we can do is convert into a surgical airway. I will explain what surgical airway is later. Okay. So I said there are ways to assess a patient with difficulty in airway. For example, doing this in emergency setting might be difficult. difficult. But it's important for you to know that there's this criteria, Lemon criteria, that is used to assess the ease of intubation. But saying that, we don't wait and do calculate Lemon scores in an emergency setting. What is good for you to know that there's a criteria like this to assess the ease of intubation. Okay, what is Lemon? Lemon is L is look externally. We look for indication that this will be a difficult intubation. For example, significant facial trauma. Basically, the face is deformed by a trauma, and we expect there's trauma to the airway also, and it will be difficult for us to visualize the vocal cords. Large incisors, the teeth, for example, like a rabbit, the teeth are very large, so it's difficult for us to maneuver the laryngoscope and visualize the vocal cords. Large beard, large mustache, large tongue. These are all features that will indicate us that intubation might be difficult in this patient. And they evaluate the 3-3-2 rule. That means the distance between two incisors should be at least, if it's more than 3 finger breadths, that means it is good. If it is less than 3 finger breadths, that means yes, there will be difficulty in intubation. And the distance between the hyoid and the mentis is the tip of the jaw, and the hyoid is at the base, at the floor of the mouth. The distance from the mentis to the hyoid bone, if it is less than 3 finger breadths, yes, there's a difficulty in, there could be a difficulty in intubation. And then thyroid to mouth distance. So from the thyroid notch to the floor of the mouth distance. If it is less than 2 finger breadths, yes, there could be a chance of difficult intubation. And we check the Malampati score. If the Malampati score is more than 3, yes, the when the Malampati score increases, the more chance that we think that the intubation will be difficult. And then we look for obstruction features, presence of any foreign bodies in the oral cavity, whether there's a blood, vomitus, this all can cause obstruction. And then neck mobility. Imagine a patient with very short neck. That will be indicated that this intubation might be difficult. So this Lemon airway assessment, you need to know that there is something called like this. But saying that, we don't wait and do Lemon assessment, full Lemon assessment. We don't check the 3x3, 3-3-2 rule at a trauma setting. We try to intubate no matter what. And this is the Malampati score. We look at the patient's forces and the uvula and the tongue, and we makes into 4 grades. So in grade 1, we can clearly see the soft palate and the complete uvula. But in class 2, we can only see part of the uvula. Only the tip, we can't see the tip of the uvula. In grade 3, class 3, only a small part of the uvula can be seen, and the rest can't be seen. In class 4, the soft palate is completely gone. We can't see the forces. That means this patient will have significant difficulty in intubation. So if we know this, then we will be better equipped when we try to intubate. We will be having our laryngeal video laryngoscope. We will be having our gum bougies. We will be giving our backward, upward, rightward pressure. And if everything fails, we will have our surgical team to provide us with definitive surgical airway. Okay. So what is a surgical airway? So if the endotracheal intubation fails, or if there's a laryngeal fracture, then a surgical airway is indicated. There are 2 types of surgical airways: elective and emergency. In this patient, like trauma patients, we do emergency surgical airways. Emergency surgical airways can be divided into 2 types: needle cricothyroidotomy and surgical cricothyroidotomy. If you know these 2 names, that will be enough. you don't need to know how to do a needle cricothyroidectomy or surgical thyroidectomy. If you basically know if the airway intubation fails, our next option is to go for surgical airway. These surgical airways can be classified to emergency and elective. And emergency we can again classify as needle and surgical cricothyroidectomy. That will be enough for your level. All right. Okay. So this is how you perform a surgical cricothyroidectomy, which you don't need to know at all. I just put the photo picture just for the completion's sake of the lecture. Okay. So imagine now we have placed our endotracheal tube. Now we have checked the bilateral airway, bilateral breath sounds, and they are adequate, and we confirm the position within the trachea, and the airway part is done. Okay, what comes next is the breathing and ventilation. So we have put the airway. Now we need to ensure the adequate breaths are given to the patient, and the patient can ventilate, use those breaths to ventilate. So we should do that. So how do we recognize problems with breathing and ventilation? We should have a high suspicion when there's direct trauma to the chest, blunt or penetrating. There's a high chance there could be a underlying injury to the lung. For example, in the pediatric age group, there may be blows to the rib cage will not cause fractures because the rib cage is in pediatric population is very plastic. The plasticity is high, so they won't fracture. But the underlying lung could be contused. So we should have that idea in our head when you see this patient. Old age groups with already existing lung pulmonary dysfunction. For example, patients with COPD, patients with tuberculosis, patients with basal atelectasis, patients with lung mets. Imagine they come with pulmonary injury with thoracic trauma. Then they are already their reserves are low. So their ability to tolerate an injury is already low. So they will deteriorate faster. So we need to identify these problems earlier in these groups of people. And imagine a patient coming with cervical spine injury and there's respiratory muscle paralysis. Only the diaphragm is working. Diaphragmatic muscle is working and the patient is breathing through this abdominal breathing. We need to look and identify these. Okay. So how do you assess a patient for breathing and ventilation? Again, we look at the patient, we listen to the patient, and we palpate and feel the patient. This is the principle. We speak again. If we have spoken, we have spoken to the patient. If the patient can answer us, then we know there's adequate ventilation. The patient can develop breaths so that the breathing is not either fully compromised or normal. All right. Then we observe for the patient. We expose from the neck to the abdomen and we look at the patient's chest and the neck. We look at the patient's chest wall expansion, whether it's symmetrical, whether it's asymmetrical, whether only part of the chest wall is expanding or both are expanding. Whether the patient is using all these accessory muscles, for example, sternocleidomastoideus, scalene muscles, whether the patients are using these muscles for respiration. Engorged neck veins. For example, in tension pneumothorax, the neck veins might be engorged. So we look for those. Segments with paradoxical movement. For example, in flail ribs, flail rib fractures. Flail rib fractures is when there's two or more ribs are fractured at two or more sides. So that part of those ribs will move independently to the other chest wall. So in inspiration, when the lung chest wall expands, this flail segment will go inside. Did you understand? Because the flail segment doesn't move with the chest wall. Chest wall move outwards for the lung to expand. When the lung expands, there's negative pressure. since that small fail segment is not attached to the chest wall due to the negative pressure, the chest wall, that part will sink inside. I hope you understood. And when in the expiration, when the chest wall comes back, the chest wall retracts back, the flail segment will come out, will bulge out. Okay, that's called paradoxical movements in respiration. And then we look for bruises and injury. We look at the respiratory rate, whether the patient is gasping for air, tachypneic, and we can look for cyanosis. Cyanosis is a late sign. So the patient without cyanosis, you can't say he's not in respiratory distress. It is a very last sign that develops. Okay. Okay, then we listen. We listen for abnormal breathing sound. We auscultate, and we listen for abnormal breathing sound, and feel, palpate, percussion, again auscultate, and pulse oximetry. We palpate the chest wall for rib fractures, for subcutaneous emphysema. We look at the chest wall expansion, whether it's symmetrical or asymmetrical, whether only one part of the hemithorax is expanding. And we look at the position of the trachea. The trachea might be deviated to one side in case of a massive pneumothorax or tension pneumothorax. We percuss the patient. Now, percussing a patient at a busy emergency room is not possible because we might not hear, but we can do percussion. In case of pneumothorax, the percussion will be dull. But in case of a pneumothorax, there will be hyporesonance in percussion. But these findings might be difficult to hear in an ER. But for MCQ setting, you need to know this. Okay, and auscultation. We listen both the lungs, the air entry sounds of the both sides of the lung, and they should be reduced in hemothorax or pneumothorax. And we can apply the pulse oximetry and check for patient's saturation. But pulse oximetry is not very reliable in patients with blood loss because with anemia, the pulse oximetry tries the reliability of the pulse oximetry is low. That you need to keep in your mind. Okay, so this is how we look for symmetrical chest movements. So we basically keeps our hands and our fingers at the midline, and then we ask the patient to inspire. If the two fingers separate, go towards opposite directions in an equal manner, then that is equal respiration. Imagine the left side is not moving at all and the right side is moving. That means the left side air entry is very low or minimal. This is how you examine for symmetricity of chest wall expansion. You can do it in the anterior side also. And the management. We ensure that the patient gets adequate oxygenation with high flow oxygen. We intubate and ventilate and treat the life-threatening condition such as tension pneumothorax, massive pneumothorax, and open pneumothorax. So what is tension pneumothorax? There's air building in interpleural space which pushes the lung and the mediastinum to the other side. That is why it's called tension pneumothorax. Because of that, the air entry to that affected lung is reduced, and as well as the cardiac output also reduced. Massive pneumothorax. Again, blood accumulates in the interpleural space, which pushes the lung to the opposite side and the mediastinum to the opposite side, which causes decreased air entry to the lung, and there's reduced cardiac output. Open pneumothorax, where there's a communication between the interpleural space and the external environment. So the air doesn't build up, but air comes in and goes out with ventilation. But when there's an open pneumothorax of more than 3 centimeters, the respiratory drive is affected. The lung can't expand in inhalation properly. So there's reduced ventilation of the lung. These are very technical terms. You don't need to know those things. If you just need to know that the life-threatening conditions involved in the breathing and ventilation, the B part of the ATLS is the tension pneumothorax, massive pneumothorax, and open pneumothorax. So if you know that, that is enough. And how to manage those. So for example, tension pneumothorax, and we should immediately relieve the decompression. We are needle thoracostomy and over finger thoracostomy. And once that is achieved, we can put an intercostal IC tube. For pneumothorax, we put a slightly smaller IC tube, but in hemothorax, we put a large IC tube because the blood can clot and clog the tube. So we put a larger IC tube. In open pneumothorax, we need to create a flap to close that opening so that ventilation can happen again. Ventilation can happen effectively again. Okay. So that is the breathing part. So up to now, are there any questions with you regarding what I said, with something that you have not understood? Are there anything that you need clarification? Anybody have any questions? Okay, I hope the silence is because you understood everything. If you have not understood everything and you need some clarification and you are not very keen in talking, please then put a message. We'll look at it at the end of the lecture. Okay. Okay. Then comes the part C of the ATLS: hemorrhage, circulation, and hemorrhage control. So hemorrhage is the most predominant cause of preventable death. Therefore, once the tension pneumothorax and massive hemothorax is excluded, unless proven otherwise, if a patient is having hypotension, you should suspect there's an ongoing hypovolemic hypotension. So we exclude tension pneumothorax and massive hemothorax in the breathing component. Then still the patient is hypotensive, then we should suspect there is some kind of bleeding happening somewhere. The bleeding can happen in, there are 5 areas there bleeding can happen: chest, abdomen, that is 4, and floor. So it's called chest, abdomen, pelvis, long bones, and 1 on the floor. That means external bleeding. The patient might have bled a liter or 2 liters at the site of injury, and they have put a tourniquet and brought the patient. And we think there's no bleeding at the moment, but patient has already bled 2 liters. That means he has lots of considerable amount of blood without evidence, with that clear evidence for us. So that is a hidden bleed. We should know. We should be aware that those are possible. Okay. So types of shock. It could be most of the time in trauma, it is hypovolemic shock. Just to cover what are the types of shock, there could be obstructive shock, such as in cardiac tamponade, cardiogenic shock, such as in heart failure, distributive shock, such as in endocrine, neurogenic shock and anaphylactic shock, endocrine shock, also kind of a distributive shock, and hypovolemic shock. This hypovolemic shock is the most common cause for shock in trauma, followed by obstructive shock. Okay. All right. I hope you understand. These types of shock I put here just to talk about it, so you get a small idea of what are the types of shock, because this is important topic. Even this endocrine and distributive shock are not very relevant to the ATLS part. Okay. Okay. In hypovolemia, now imagine the patient is bleeding. Okay. So what does the body do? There's ongoing bleeding. So body has some kind of homeostasis. So what is homeostasis? Homeostasis is when there's changes in the external environment, the body try to stay still, try to maintain its own rhythm. There's changes in the environment. but we try to maintain ourselves. For example, somebody shouting outside and I can't conduct the lecture. I want to conduct the lecture. So I will go to another room and I will try to conduct the lecture. That is homeostasis. I try to maintain my normal routine. That is what the body will try to do when there's hypovolemia. So what can the body do? So first of all, the body will there are reserves in the body. For example, there's a spleen where there's reserve blood in the spleen. So there will be splenic contraction, and this blood will be taken into systemic circulation. That is one method of homeostasis achievement. And then come the vasoconstriction. So the body identify the important organs for life. What are those? The heart, the brain, and the kidney. The kidney identifies, the lung, the body identifies. These are the most important structures that is important for continuity of life. So what it does is, it reverses blood supply to these three organs while shutting down the blood supply to other organs. What are the other organs that the body thinks, okay, they don't need blood, they are useless? So what are those? Those are skin, muscles, and guts, the intestines. So they revert blood from those to the heart, brain, and kidney. And organs like heart, brain, and kidney, they have their own auto-regulation of blood. Despite changes in the blood pressure, they can they also have their homeostasis, where they try to maintain their blood flow by different methods. You don't need to go on detail how they maintain their blood flow, but there's some concept called auto-regulation of blood flow. Despite changes in the hypotension, the brain, kidney, and heart can keep their blood flow at a regular level up to within context, up to a certain level. Therefore, this compensating methods, there's a limit of it. This can't go on, keep going, because the patient is bleeding out continuously, and the body can't compensate continuously. There's a limit, and at that limit is the decompensation. So before the decompensation happens, we should do a hemorrhage control. We should control the hemorrhage and then replenish the intravascular volume. Now there's some blood lost, so we need to replace it and stop it. Those are the two principles: stop the bleeding before the body decompensates and replenish what is lost. Okay. Okay, then we'll see. This is the basic principle. We'll see how it is done. So this is what I said. This is the renin-angiotensin aldosterone system. There's I just put it for the completion's sake. So when there's loss of there's hypovolemia, the juxtaglomerator apparatus detects it and secretes renin, which goes and activate the angiotensinogen, and angiotensin then converts into 1 and 2, and 1 angiotensin 1 increase the sympathetic activity as well as arterial vasoconstriction, and increase reabsorption of fluid from the kidneys. These are a few things that is relevant to physiology. This won't be asked you in the surgery MCQ paper, but it's good to know so that you know the concept of it. All right. Okay. So that's how the vasoconstriction happens. Okay. So as I said earlier, the major sites of blood clots are the chest, abdomen, pelvis, long bones, and the external hemorrhage. That is one on the floor is the external hemorrhage. So how do you recognize a patient with shock? There are classes of hemorrhagic shock, class 1 to 4. So how do you identify the patient? The earliest sign of hypovolemia is tachycardia. That is the first sign to appear is tachycardia. Patient will develop high increasing heart rate. But we need to keep in mind, adult patients on beta blockers may not have tachycardia because their ability to increase the heart rate is blocked by these beta blockers, because the beta blockers will prevent the sympathetic activation and sympathetic activity, and then it will not have the tachycardic effect. So we need to keep that in mind. Okay, that might come as a MCQ. Okay, and cutaneous vasoconstriction, as I told earlier, the extremities might be cold, distal pulses are barely palpable, and altered neurological status at the decompensation level. When there's reduced blood flow to the brain, there will be altered neurological status. For example, in class 3 and class 4 shocks, there will be confusion and lethargy in the patient. We'll see what are the classes of hemorrhages. So this is the 4 classes of hemorrhages according to the blood loss. Less than 15% of total body volume loss is class 1. Between 15 to 30 is class 2. Between 30 to 40 is class 3. And between more than 40% of the blood volume loss is class 4. This amount of milliliters is basically in an adult patient of roughly 75 kilogram patient. So you need to, if you have a rough idea, that's fine. Okay. So in class 1, you see the earliest sign is, the only sign that may be there is high blood pressure in class 1. In very healthy adults, in class 1, even high pulse, high tachycardia is not there, because they have a good compensation, and that what I said in the splenic reserve might be enough to replenish the lost volume. So there might not be tachycardia. Okay, so in class 1, but in some people in class 1, they may have tachycardia, and the blood pressure is completely normal. The systolic blood pressure is normal. The pulse pressure is the difference between the systolic blood pressure and the diastolic blood pressure. It is normal. Capillary refill time also normal. Respiratory rate normal. Urine output is maintaining at a very good rate. Mental status, the patient will be anxious because of the pain. Otherwise, patient will be normal. No changes in mental status. But when it comes to class 2, that means 15 to 30% of total body volume blood loss. 15 to 30% of blood loss. At that point, there is tachycardia. Tachycardia is well established. There's tachycardia above 100. But still, the systolic blood pressure is normal. But as I said, there's vasoconstriction happening. So the diastolic blood pressure increases and the systolic blood pressure stays same. Still the compensation is ongoing and vasoconstriction has happened. Vasoconstriction increases the diastolic blood pressure. So the diastolic blood pressure increases and the pulse pressure, which is the difference between the systolic blood pressure and the diastolic blood pressure, decreases. So the key point in class 2 is that in addition to the tachycardia, there is reduced pulse pressure. Okay, this you need to understand. This reduced pulse pressure is the added indication in the class 2. And capillary refill time will be slightly longer. Respiratory rate could be a little bit higher, and urine output is still maintaining. And at this stage, the patient might be a little bit anxious. And then comes the class 3. Class 3 is where there's 30 to 40% of blood loss. So in the pulse rate is, there's significant tachycardia there. And the key feature is that now this is the point where compensation is failing. Now this is the decompensation part. So there's decrease of systolic blood pressure. Now the compensatory mechanisms can't handle it anymore. So the systolic blood pressure is dropping down, and the sympathetic activity is rising up still, and the diastolic blood pressure is rising. So the pulse pressure is furthermore decreasing. Capillary refill time will be increased, and now the respiratory rate increases furthermore, and the urine output reduces. But still it is there, but reduces, because the renal perfusion is starting to get effect now. So the urine output is reducing. And here comes the neurological alteredness. So the patient will be confused, not lethargic, but confused in class 3 shock. That means there's decreased perfusion to the lungs and the heart and the kidney. Urine output decreases and the patient is going confused. So this is the point of decompensation. And if the blood flow keeps on going and more than 40% of the total blood volume is lost, that is called class 4. And this is totally beyond compensation. Now this is completely decompensated, and at this point the life is not compatible. So we need to reverse it So there will be significant tachycardia, and the BP is, the systolic blood pressure would be very minimum and might be even unrecordable. Pulse pressure is very low, and basically no urine output because the kidneys has completely shut down because no blood flow to the kidney now. Urine output is basically negligible and the patient is lethargic. There's very low blood supply to the brain and the brain can't function. So the patient is basically lethargic. So that is how you identify 3 classes of shock depending on the pulse rate, blood pressure, and the pulse pressure, and the urine output and the mental status. These are the important factors. So I hope you understood this table because it is important. Depending on what class of shock, the management differs. For example, the need for blood in classes 1 is almost nil. You don't need blood products. But in class 2, yes, there could be a chance for blood products. But in class 3 and flow, blood products is an absolute must. And that too, even uncross-matched blood might be needed for these patients. That you need to understand. Because of that, understanding this table is very, very important. So is everybody clear on this, or you need more clarification on this? Please let me know because this is very important. You are happy? You understood? Okay. So depending on that, blood transfusion maybe is not needed in class 1, but in class 2, it is a possibility. In class 3, definitely yes, we need it. We need blood, and even we might need uncross-matched blood. In class 4, blood is an absolute must, and a simple packed RCC might not be enough. The patient might need to go to massive transfusion protocol where we give packed red cells as well as platelet and FFP. Because if we keep giving only packed red cells, now the blood we lose blood, and along with blood, the plasma is also lost. Along in the plasma, the clotting factors and platelets are also lost. So by just giving red cells, these clotting factors and platelets are not replenished. So the coagulopathy is going to further rise up. So the bleeding is further worsen. So we need to give platelet and free frozen plasma also. So that is where we go for massive transfusion. We give red blood cells to platelets to free frozen plasma in 1:1:1 ratio. This might be asked in your exam as a MCQ. So it is important to know massive transfusion protocol. Okay. So how do you manage? So initial airway and breathing assessment we have to complete first. Once it is there, control active external bleeding. Apply compression, apply tourniquet. If they apply tourniquet, if the pressure fails to stop the bleeding. But we need to understand that if we apply a tourniquet, there's a risk of ischemia to the distal part of the tourniquet. The distal part of the body beyond the tourniquet, the risk of ischemia, and we should be aware that we had applied a tourniquet. So, and we need to try and remove it. And if there's a suspected pelvic fracture, apply a pelvic binder to compress the pelvis to prevent further bleeding in the pelvis. Okay. How do you initially manage? We need rapid large bore venous access. We put two large bore peripheral vascular access, at least 18 gauge, that is green. Smaller cannulas are not suitable for this. For example, pink, blue, yellow, those are not suitable. At least 18 gauge. Green or above, green, white, gray or orange is needed for this. Two vascular access. If the vascular access is not there, we have to go for central venous access. And in children, we might go for intraosseous access. And we take blood flow samples. We need to send blood for grouping and DT for blood transfusion in the future. Basic investigations such as full blood count, serum electrolytes, PT-INR to check for coagulopathy, serum creatinine, and in the childbearing age, a pregnancy test, serum for blood for serum beta HCG should be done. But saying that, we don't have the facilities in our country. So this is not done routinely in our country, but the ATLS protocols dictates that it should be done because of the legal problems, and we don't know the mother is pregnant just by looking at the patient. So if the patient is in the childbearing age, we should do it. But given the restrictions of our country's health sector, this is not done routine. But if there's an MCQ saying is pregnancy test serum beta HCG test indicated in the initial blood workup in a trauma patient, yes, it is true. Just know that is enough. Don't think about it much. If they question like that, it's a true statement. And then arterial blood gas. If, as I said earlier, if peripheral vascular access we fail to gain it, we should go for an alternate route, such as intraosseous action or central venous access. Intraosseous access might not be feasible in adults because of the higher bone density, but in pediatric population, yes, intraosseous access is a possible route if the peripheral vascular access is not available. So we gain the IV access and we send the blood workup. What to do? So we need to, now the patient is losing blood. So we don't have blood immediately. As soon as the patient comes to the emergency room, we don't have blood there. What we have is crystalloids. But we need to replenish his intravascular volume. So there is some kind of perfusion to the end organs. So what we can do initially is give crystalloids. We should give at least 1 liter of crystalloid, either normal saline or inverse lactate, as an fluid bolus. And in pediatric group is around 20 ml per kg if the body weight is less than 40 kilograms. And we don't when we resuscitate this patient with fluid, we try to, our goal is to achieve a systolic blood pressure of between 70 to 90. This is called permissive hypotension. That means we are keeping the systolic blood pressure in the borderline between hypotension and normotension. Why are we doing that? We keep at this level, so there's adequate organ perfusion while trying to not increase the blood pressure further. Because if we increase the blood pressure to a higher level, the clots that has been already formed at points of bleeding might pop out. So imagine you have plugged a water pipe at your home. You have plugged a water pipe, and you go into your water tank, and you apply pressure. What will happen to that plug? That will plug. If the plug is downstairs, the plug will try. Sometimes the plug will just pop out. And what will happen? The water will come out again to the water pipe. So in order to prevent that, we don't increase the blood pressure to a higher values. We keep it at a range of like 70 to 90 millimeters mercury, where it is enough to perfuse the end organs while trying to keep the clots that has been formed intact to prevent further bleeding. You got this idea? This permissive hypertension concept is very important, and it might be asked in the MCQ and even in the SBA. They might not ask by the name permissive hypertension, but they might ask in a radical way, like at to what level of BP is your target, like that. So they are questioning about permissive hypertension. So I hope you got it. If anybody have difficult did not understand, just let me know. Anybody? Okay. And this fluid that we give to the patient, it should be warmed, because if we give normal fluid that is sitting on counters, there's a temperature difference, and it could lead to hypothermia of the patient. And hypothermia in coma patients is a killer. We don't want that. So we should give warmed fluids. If it just fingers lactate, we can warm it in a oven, a microwave oven. But blood products, we can't do like that. Blood products need to be warmed in a blood warmer. We basically run the blood through a blood warmer and give to the patient. And excessive fluid resuscitation can cause dilution coagulopathy, as I said earlier. And over resuscitation with higher pressures can also lead to further bleeding. And patients with existing heart failure, if we give too much fluid, they will go into fluid overload. So we should have that also in our mind. Imagine a patient comes with significant heart failure. You might not be able to give a 1 liter fluid bolus at a go. You might need to reduce that amount of fluid bolus and get blood earlier. So, okay, we have given 1 pint of bolus to this patient. And how do we know whether the bolus had an impact or not? Whether the fluid bolus did the job that we want to do or not, or partially did it. So that is called assessing the response. We assess the response by assessing patient's parameters. We look at patient's heart rate, pulse pressure, blood pressure, the urine output, and the serum lactate levels. And with that, we assess the patient with a rapid response, transient response, or minimal or no response. Okay, so in rapid response, the vital signs return to normal in a very fast manner. But in transient response, there's an improvement, but then again the pressures and the heart pressures decrease and the heart rate increase. And if there's a minimal or no response, even though you give a fluid bolus, there's no improvement. It basically it worsens. It worsens rather than any improvement. Okay, so rapid response is expected in class 1 hemorrhage. Transient response is expected in class 2 and 3, and minimal response is expected in class 4. So if there's rapid response, the chance for need for blood transfusion is low. But if there's transient response, there's improvement and then there's deterioration. That means the body is ready to answer to us, but it is still losing blood. So we need to give blood. Giving just fluid is not going to work for this patient. So we need to give blood. So that is for transient. Minimal responses means that even the fluid that we are giving is not useful to him, because the blood load is so much. The fluid that we are giving fails to do anything. So this patient needs definitely blood, needs emergency blood, uncost-matched blood. Okay, and need for operative intervention. Rapid responses, yes, sometimes they need. Even they respond, there's a hypertensive part. So there might be an injury that is causing bleeding. So we need to explore it. Yes. So surgery might be needed, might not be needed. We might be able to minimal intervention methods such as angioembolization. We can go through the artery and embolize the bleeding artery. So surgery is not always needed. Transient response, surgery is very likely because there's ongoing bleeding somewhere because it responds now crashing back. That means some bleeding is going on. We need to intervene. And then minimal response is definitely we need to intervene because there's so much blood loss. Even the fluid bolus is not going to equate. Okay. So blood displacement. So imagine the patient is transient responder or no responder. So we need blood. If it's a transient responder, we can some depending on patient's status, we can wait for cross-matched blood or uncross-matched blood. But in no responders, we can't wait for cross-matched blood. We have to get down uncross-matched group or rhesus negative blood, RH negative blood. Got the idea? So cross-match packed RB is preferable because the chances of transfusion reaction are low. But it takes at least 1 hour for the blood bank to process and cross-match the RBC packed red cells available in the blood bank with our patient's blood. And it takes at least 1 hour, but the patient might not have 1 hour. In that case, we need uncross-match O negative packed red cells because we know group O, blood group O is the universal donor. They can give to anybody. Group A, group AB, group B, they can give to anybody. And being rhesus negative also, that is, for example, patients in the childbearing age where they have not, then O negative is beneficial because it won't sensitize the patient for rhesus factors. So uncross-matched type O negative blood is preferable in emergency situation. You got the point there? Because this can be asked in SBAs. What are you going to do? Uncross-matched type O negative blood or cross-matched blood or continue fluid resuscitation with crystalloids or anatropes. They can answer like this. So what is the question? What is the answer? So they can question like that in SBA. So you need to know this principle. It's simple principles. If there's already blood, depending on the response, minimal response, rapid response is there's good response. That means maybe the blood bleeding has already stopped. The blood products might not be needed. The amount of fluid that we have given might be enough. Blood might be needed, but there's a chance that it might not be needed. In transient, we give the bolus, fluid bolus, and there's a reaction to it because that is enough for the body, but still the blood is losing. The patient is losing blood. So what we give also is losing. So there's initial response and then there's a deterioration. So then there is a need for giving blood because patient is losing blood. There's no point of giving continuing fluid. If there's no blood available, yes, fluid has to be given. But we need to get down blood as soon as possible now. In minimal response, there is no response. That means the blood loss is so much. The one bolus of fluid that we have given is basically useless to the patient. It's like pointless. It's like a small boat going under the Calais bridge. So basically useless. So blood is definitely needed for this patient, and that blood also we can't wait. We need uncross-matched type O negative packed red cells. That is the concept. Just by heart it. Why we give blood rather than fluids? Because blood has the capacity of carrying oxygen to the end organs. The crystalloids doesn't have that. Crystalloids are just fluid, just normal saline or ringless lactate. They don't have a blood oxygen carrying capacity. That is there in the packed red cells. So we need to give blood to ensure that the end organs are adequately perfused. Okay. I hope you understand. If anybody didn't understand, just let me know. I will repeat it once more. Okay, everybody fine? I hope you guys are not asleep. Just joking. Okay. So, blood replacement. As I told, there's a protocol called massive transfusion where we give blood RBs, the red blood cells to platelets to FFP in 1:1 ratio. These are indications where we give massive transfusion protocols. You don't need to know these. Just if you are interested, just have a memory, but it is not necessary for you to know this for the exam. It is highly unlikely you will be questioned on what are the indications for giving massive transfusion protocols, because that decision is not at the level of an HO. That decision is at a senior level. Okay, if you know that there's a thing called a massive transfusion protocol, that will be enough. And as I said, blood should be warmed before administering with fluid warmers, because there's a risk of hypothermia. Hypothermia is a killer in trauma patients. We need to prevent. And there's this new concept called cell savers. For example, the patient is bleeding his own blood. If we can collect those bleeding blood, for example, there's a hemothorax and we have put an intercostal tube, okay, IC tube. So there's blood coming through it. We can use that blood to transfuse the patient because it's his own blood. We can use that blood to transfuse them. These are called cell savers. In Sri Lanka, I don't think it's available. I have never seen. But in the Western countries, this is a new concept that is coming and that is available. So we can give patient's own blood to him after some procedure or some process to purify it or somehow, and we can give his own blood to him. That is the concept. So if you know it, that's better. But I don't think you will be questioned on that. Just know that this option is there. For example, if you say this if you say this as at the end of your discussion in the emergency viva, you might get a distinction point. But if you said initially, at the first end, I will use cell saver, that it will be look ridiculous. But if you said at the end of the discussion, I have the option of using a cell saver also, but then it will be a distinction point. So it's good to know. Okay. And then we have to catheterize the patient. Because we have to measure the patient's urine output to assess the renal perfusion, measure the vital signs of the patients, the blood pressure, the pulse rate, the respiratory rate, the saturation, those things. And we can give IV tranexamic acid. Tranexamic acid is a fibrinolytic, antifibrinolytic agent. So it prevents the lysis of fibrin. So the clot formation is augmented. There's evidence that it has a survival benefit in patients in trauma. If they present within 3 hours of injury, giving IV tranexamic acid 1 gram bolus over 10 minutes, followed by 1 gram infusion over 8 hours, has a survival benefit. But that is if the patient presents within 3 hours of the injury. After 3 hours, there's no evidence to say that it is effective. So it is proven in a landmark trial. You don't need to know this. I'm just saying this for interest's sake, that it has survival benefit. And then, most importantly, we need to go for definitive hemorrhagic control, because there's no point of keep giving blood if the patient is losing blood. We basically make a hole in the pot and we try to fill with fluid. So we will fill fluid and the fluid will go and dribble down from the low vein. So there's no point. We should seal the low vein and then pour fluid over. If we just if we just pour fluid, it will just go. So we need to go do definitive hemorrhagic control. It could be either surgical intervention or it could be an angioembolization. As I said earlier, we can go through a vascular access and go to the place where it's bleeding and we can embolize that bleeding vessel. That depends on the grade of the injury. We can't do embolization for everything. If it's a minor bleeding, for example, liver laceration of grade 1 to 3, yes, there's a chance for angioembolization. But 4 and 5, most likely surgery is needed. Like that, it depends. The options are either surgical or angioembolization. Depends on patient's factors. All right. Okay. Imagine now we have gone through the C also. There's no problem in C also. Patient is completely fine. Then we go to the disability and neurological evaluation, the D part of the ABCD. We assess the patient's Glasgow Coma scale. We assess the patient's pupil size and reaction. We look for lateralizing signs, spinal cord level of injury, and the anal tone. These are, and we have to check the spine for palpable fractures and tenderness. Those are the few things that we have to check in disability and neurological evaluation. So this is a GCS score. GCS score you must know. So they can give a SBA, giving you, for example, the patient is responding to opening the eye when you speak his name. The patient withdraws his finger when you put a small prick, and the patient talks back to you in single words. What is the GCS score? They can give you this as a SBA. So if you know the GCS score, it will be good. So knowing GCS score is important. So GCS score has 3 components: the eye component, the motor component, and the verbal component. So the eye component is ranked out of 4. The motor component ranked out of 6, and the verbal component out of 5. So let's talk about eye. If the patient is spontaneously opening and closing his eye, the patient is basically awake, and patient is spontaneously closing and opening the eye, then the eye component is 4. If the patient is basically is on shut eye, and he's keeping his eyes shut, but the patient will open and look at you when you speak his name or make a loud sound, then the GCS either component is 3. But if the patient does not respond to voice, but you pick the patient and he wakes up, then its GCS eye component is 2. And if there's no response at all in the eyes, it's 1. It's never 0, because the lowest GCS that the patient can have is 3. A dead patient will have a GCS of 3. Okay, so you can't. The lowest is 1. And for motor, if you give a command to the patient, okay, lift up your hand like this. If the patient does that, is GCS motor compartment 6. If the patient can localize the pain, where is the pain? He can basically localize. If you prick the foot, and patient can localize the pain, that is GCS 5. If you prick the patient and patient try to withdraw the hand, then it's GCS 4. Okay. If there's abnormal withdrawal, abnormal flexing, that is GCL, the motor component 3. If it's abnormal extensor response, such as in this image, is 2 and nil is 1. Okay. And the verbal component, if the patient is well oriented, he can basically answer your questions. Where are you from? I'm from Gampa. So that is verbal 5. If the patient answers to you but is confused, he can't tell the answer in one go. He will need multiple questionings, and that question also he can't, but he can speak, but he has difficulty in understanding and explaining. That is confused speech. That is 4 out of 5. If the patient is just saying single words, only one word, and those sentences doesn't make any, what he says doesn't make any sense, but those are words, then the GCSE, the verbal component is 3. And sometimes the patient will be aggressive and they will be shouting out foul language and word. Then that also comes as GCS, verbal component of GCS 3. And then if the patient is only able to emit some sounds, or like that, only sounds, not words, just sounds, then the verbal component is 2. And if no sound or nothing, is just 1. I just explained to make you familiar with the GCS. If you know this, it will be better for you because it can be questioned in an MCQ. Okay. Okay. So what are the causes for low GCS? It could be due to hypoglycemia. Simple as that. The patient might not have eaten. Patient might be drinking through the entire night. He has not eaten for a long time. He on the way home, he gets knocked down by a car. There's no head injury, but the patient is hypoglycemic. So we should always have these thought processes in our head. Intoxication. The patient might be under influence of either substance or an alcohol. Hypoxia to brain. There's hypovolemia and there's low blood perfusion to the brain, and the patient is hypoxic. So low GCS. As I said earlier, grade class 4 hemorrhage will have confusion. Lethargy. So that is a feature of hypoxia to brain. And primary injury to the brain. Just associated primary injury to the brain, then yes, it also can cause low GCS. So this is a template where in the national NHS, the National Health Service in UK used to assess spinal injury and head injury with the hematomes and myotomes. This I just put for the sake of completion. You don't need to know, you don't need to buy hard this or anything. If you know what to do to check in the neurological examination in the D component of the ABCD, that will be enough. Okay, now we have gone through the D also. We have look at the patient's GCS. We have evaluated the GCS. We have look at the patient's pupils and assess the reactiveness, whether they are equal reactive or not. We have looked for lateralizing signs like hemiparesis of one side, facial nerve palsy of one side. So, and we have look at the spine, check for the spinal tenderness and fractures, and we log the patient and check for the anal tone, and it's all normal. Then we go to the exposure and environment control. So we have to completely undress the patient for full secondary examination. If the patient is having any contaminated dressing, for example, these patients who were in the bus during the road traffic accident, they might have glass pieces in their dressings, so contamination. They might have gasoline in on their dressings, so contaminated. We have to remove these contaminated dressings, and once they have removed it, there's a chance that patient can be fallen into victim of hypothermia. So to prevent hypothermia, we have to wrap the patient with warm blankets, because hypothermia is a killer that we rarely identify, because that can aggravate the injury, that can reduce the patient's compensatory amount. So the patient might decompensate earlier in the background of hypothermia than a patient with normothermia. Okay. Okay. So that is the primary survey. Now we have finished the primary survey. And now there's thing called adjuncts to the primary survey. Now the primary survey, all I said was clinical assessment. We basically assess the patient clinically. But there are some adjuncts, some things that we can use during the primary survey to benefit our diagnosis. Okay. So in airway and breathing, we can use adjuncts such as pulse oximetry, capnography to check whether the endotracheal tube is adequately placed in the trachea, ABG, arterial blood gas, X-rays. X-rays of chest X-ray only. Other X-rays are not a part of the primary survey. Chest X-ray, yes, it has a chance, but to do a chest X-ray, there are portable X-ray machines. Chest X-ray is part of the as an adjunct in the primary, if only a portable X-ray machine is there. If you have to take the resuscitating patient to a X-ray department to take a chest X-ray, then it doesn't become part of the adjunct. So you can say chest X-ray is part of the primary survey adjuncts, but with context. Okay. Okay, and NG tubes to decompress the stomach to reduce the risk of aspiration, and we can aspirate and see whether there's an upper GI bleeding, that is bleeding within the upper gastrointestinal tract. We can check for it, and NG tube is contraindicated if there's a suspected cribriform plate fracture, because that NG tube can pass through the cranial vault. And the adjuncts to the circulatory part, the vital monitoring with the monitor, ECG, fast scan. So what is a fast scan? Fast stand for focused assessment with sonogram in trauma. Focused assessment with sonogram in trauma. This is called fast scan. You need to know what a fast scan is. Fast scan is basically with ultrasound scan, we check for intra-abdominal bleeding. We can check for intrathoracic bleeding also with fast scan. So we check for bleeding only. We don't go and assess the organ damage, the level of the how much the organ, for example, liver laceration. We don't go and assess the architecture of the liver. We just check whether there's fluid around the liver. That's all we check. If the fluid is positive, then the fast is positive. Okay, that means there is some kind of bleeding inside. And then diagnostic peritoneal lavage. It is falling out of habit now because it takes time. And basically what we do is we insert a cannula to the abdomen, and then we insert we flush the abdominal cavity with fluid, and we let it drain out, and we look at the contents. If the content is bloody, yes, there's intra-abdominal bleeding. If the content contains pieces of feces, then we have suspicion of there's damage to the gut, gastrointestinal tract. So diagnostic peritoneal lavage. And then urinary catheterization is we have to do. It is contraindicated if there's if we suspect there's a urethral injury, for example, blood at urethral meatus, high riding prostrate, or bleeding signs in the perineum, red flags that provide suspicion of urethral injury. So in that case, urinary catheterization is contraindicated, or otherwise, to monitor the urine output, we have to put a urine catheterization as a adjunct to the primary survey. And pelvic X-ray sometimes, yes, not always. Neurological and disability, for we can do a CVS, because as I said, hypoglycemia can be an cause for low GCS, because most of these patients who comes to after road traffic accidents, a lot of them are people who are under influence. So they might not be eating, they might be just drinking. So they are CV, they might be hypoglycemic by the time they are presented to us. So we need to address that also. Okay. So I just want to discuss a little bit about fast scan and peritoneal lavage. So fast scan, the advantage of fast scan is it is readily available. It can be done as a bedside test. Basically, the ultrasound machine can be taken to the ER room, and just in a 1 minute you can assess the 4 quadrants of the abdomen and the costodiaphragmatic pieces for fluid. If there's fluid that is fast positive, is very readily available and cheap, and we can redo it if interval if we think the patient is deteriorating clinically. And the disadvantage is that it is operator dependent. So imagine there's a very new medical officer who is not very experienced in fast scans. He might miss smaller bleed. Like if the intraperitoneal fluid is not large, it's a small volume. The person who's performing the scan might miss it because he might not see it. If he has not seen it multiple times, he might not see it. For an fast scan to detect fluid in the abdomen, it should be at least more than 100 milliliters of blood of fluid in the abdomen. So if it's a smaller bleeder, then he might not pick up. So that is the disadvantage of the fast scan. It is operator dependent. Okay, that is what I want to highlight in that. And diagnostic peritoneal lavage, the disadvantage is that it takes time and it's an invasive procedure. The advantage is that we can identify if there is any damage to the gastrointestinal tract. For example, if there's fecal matter coming out of the peritoneal drain after diagnostic peritoneal lavage, then we have high suspicion that there is a gastrointestinal tract damage. So that is an important advantage. So with that, our primary survey is complete. Okay, now the patient, we have gone through the primary survey. The patient is normal. Patient doesn't have any injuries in the primary survey. So does that reassure us? For up to some extent. But by saying that, we should not rely on the primary survey that has been completed. If the patient deteriorates at a later stage, we should always abandon what we are doing and we go back to the primary survey and redo it from A to B, A to E, and assess the patient again. And because of that, we need to repeat it in intervals to check if the patient is deteriorating. This is very important. You need to understand this. Okay, so the primary survey is done. The patient is stable. So we go to secondary survey. So we take a complete medical history. If the patient is able to give a medical history. If the patient is not able to give a history, for example, patient is drowsy because of intoxication. He can't give a good medical history. So what are we going to do? So we take a short history that encompasses the most important details, either from the patient, either from the bystander, or from the EMT people. So that is called an ample history, AMPLE. So A for allergies, M for medications, any, like for example, like any anticoagulants that he might be on, any beta blockers he might be on, and past illnesses, whether he is having any past illnesses that would affect our clinical judgment. For example, patient with very low ejection fraction, heart failure with very low ejection fraction. That means like the heart is barely working, coming with a trauma. There's a hemoperitoneum, liver laceration. The patient might not survive the laparotomy. So those are important. For past illnesses, the last meal, when the patient had anything to eat, because that is important. If the patient has had the last meal, it is important for the anesthetist. So how to give the anesthesia? Because there's a risk of aspiration of the gastric contents. And the events. How does this injury occur? What type of accident? Whether it's RTA, a road traffic accident, whether this was an assault, whether this was fallen from a height, if it's so, how height, how fast were you traveling? If it's a road traffic accident, what type of vehicle? Were you the passenger? Were you the pillion rider? Were you wearing helmet? Those all are important. How did you impact? Were you thrown off? Those all are important because they will give an idea of what kind of injuries we might have to expect in this patient. For example, a patient who has been riding a bike is thrown out of the bike, and then fall on the ground with head impact. So he might have a basal skull fracture. So if we listen to his history, then we know that we might have to suspect that. So we will look at it more attentively. So the chance of us missing it is less. I hope you understood. Okay. So in the secondary survey, what we do is a methodical head-to-toe examination and front-to-back examination with respective attention to the history. With the given history, we pay respective attention, more attention to the areas that tallies with the history. We need to do a comprehensive neurological examination. Need to log roll the patient for spinal examination, check for the spinal tenderness, and if the patient deteriorates at any point during the secondary survey, the primary survey should be repeated to find the cause, because it could be a life-threatening cause that has been not there during our initial primary survey, but now it's happening. So we need to abandon whatever we are doing and go back to the primary survey. We repeat from A to B, A to E, and we identify the cause. And if we have found the cause, treat it. And once the patient is stabilized, you come back to secondary survey again. That's the principle. Okay. Okay. So, like there were adjuncts to the primary survey, there are adjuncts to the secondary survey also. So the goal is to identify now in secondary survey, our goal is to identify any kind of injury. So if there's any kind of injury, to identify it, that's our goal. Okay. So there's limitless options as adjuncts. Basically, if there's any type of blood investigation, any type of imaging, that comes as adjuncts to secondary survey, because we can do anything. Okay. So if indicated full X-ray series, if spines, extremities, chest, abdomen, anything, cervical spine, CT scan of the head, computer tomograph scan of the head, chest, abdomen, spine. In polytrauma patients, whole body CTs are done. The entire body is scanned head to toe in polytrauma patients, because there's so much injuries. We might miss some if we do a part of only. So we do an entire whole body CT. Contrast urography for urethral injuries. So basically, we inject contrast retrogradely through the urethral meatus, and we take a urograph, and we check for urethral contrast extravasation and in urethral injuries. Angiography. For example, patient is coming with compound fracture of the tibial fibula, and there's no pulse in the distal. There's no dorsalis pedis, so posterior artery pulse, low saturation, whole limb, pale limb. So there's a we suspect there's arterial injury. So we do an angiogram and see at what level the artery is injured. And depending on that, adequate the necessary vascular intervention. Bronchoscopy, transesophageal ultrasounds, upper GI endoscopy to check whether there's any upper GI bleeding. So any investigation will come under adjuncts to secondary survey. Whatever the investigation, it will come. You can do anything to check. Even a troponin I, if there's a cardiac chest injury and we suspect a cardiac contusion, we can even do troponin 9 as a biomarker. So adjuncts to secondary injury is limitless. So that is secondary survey. We identify the injury and we do the necessary treatment. For example, if a fracture, we identify what type of fracture, and then we do the necessary treatment, reduce, hold, and rehabilitate, heal. So that's the adjuncts to secondary survey. Okay. So that finishes the basic concept of the ATLS. So the primary survey and secondary survey. This is a very important concept that you need to know in and out when you face the exam, because this is a very famous area and a very hot site for SBS as well as MCQ, mostly SBS. SBS are where you can 4 marks. If you know, you know. You can just work it out if you know. So this is a very important topic that you need to know. So out of that, second price, know in and out in-depth knowledge of primary survey and secondary survey is very important. Okay, all right. So what according to what we discussed, do you have any questions before you go into the question part? Any doubts, any unclear areas? Anybody? Okay. Okay, then I will go to the questions. May I think our lecture went little bit too long, so we'll go into the questions. And if there's any questions that you have, just put in the chat box and we'll answer. So just have a look at this question. Male present with a stab injury to the right upper quadrant after an assault. His pulse rate is 120 and blood pressure is 80 millimeters mercury, and he is unconscious. What is the next management? What is the next management? So you have identified this is an SBA. What they have is the next management. Then he is unconscious. Pulse rate 120, BP 80. So give tranexamic acid bolus. Is it a management option? Yes. Intubate and ventilate. Yes, a management option. Urinary catheter and urine monitoring. Yes, it is also option in management. Connect to monitor and check vitals. Yes, it's also management plan. Chest X-ray. Might need. We don't know. So what is the next? Any idea? According to our ABCD approach, what should we do? Okay, somebody has put a message. B. Yes. Girindu. Very good, Girindu. So, yes, because what we discuss is ABCD approach. If the patient is unconscious, that is the GCS 3 out of 15. As I said, if the GCS less than 8, that is an indication for a permanent airway. We need to put a permanent airway. So, intubation and ventilation should take priority rather than giving tranexamic acid or connecting to monitors. Okay, very good. You understood the concept. Okay, next question. A 55-year-old man presents to the A&E after a road traffic accident. He is on a spinal blood with a cervical collar. He is restless and stridor is noted. Saturation is 88% and blood pressure is 80 by 60. Pulse rate of 130. GCS 8 out of 15. Which of the following is the most appropriate method to secure his airway? Most appropriate. Okay, this is not the initial management. They ask for the most appropriate method. Bag and mask, endotracheal intubation, precothyroidectomy, laryngeal mask airway, oropharyngeal airway. What do you think? Somebody has answered. D. No, sorry, C. Why would you go for cricothyroidectomy? Somebody put A. Okay. Why do you think A is? Okay, yeah, there is a cervical injury, that is true. That they have suspected cervical injury and they have put a cervical collar. That is true. But being the indication for permanent airway, so even with the cervical collar, we can open it, manually stabilize the head, the cervical spine, and then put a permanent airway. So that is not a contraindication. B. What is B? Endotracheal intubation. Yes, that is the answer. Why? Because one, his oxygenation, his ventilation is not good. His saturation is 88%. Okay, and he's restless. That means there could be some there could be a hypoxic element, and there's a stridor noted. That means there's imminent respiratory compromise arriving at us. So we need to act fast. We can't just wait around and bag and mask and ventilate and see, because there's a strider. Strider means the airway is telling us, hey man, you need to act. I'm going to throw you a tantrum in the next few minutes. You need to act now, or you are done. It's like basically a toddler asking the mother, bring me that toy, otherwise I'm going to throw a tantrum. So we need to listen to this airway, not like the toddler. So we need to address this patient then and then, put an immediate permanent airway. You got the concept? Because we can't wait around this patient. And the GCS also 8 out of 15. Even more than that, this restless and the strider is a striking features of this question. So with that, other options are totally out of the flow, and it's endotracheal intubation. Tricothyroidotomy, if the endotracheal intubation fails only, it is not the most appropriate method. It is a method as a last resort. If the endotracheal intubation fails despite everything, then yes, but not before everything. But if you can put endotracheal intubation, why not? So we have to attempt that. Okay, so I saw many of you got the answer correct. So if you understood the concept, that's the most important, not the answer. The concept is the important part, because if you know the concept, you know how to answer the next question. So, all right, okay. So 55-year-old pedestrian was brought to the A&E after an RTA. There's a large pulsatile bleed from the lower part of the right thigh. What is the most appropriate initial step to prevent the bleeding? Clamping with a hemostat, direct pressure, exploring and packing, tourniquet application, traction splint. They are asking what is the most appropriate initial step. Okay, that is, what do you mean by that? That is not the next step, but not the definitive step also. So in the initial setting, what is the best one? In the initial setting, what is the best step? Okay, now let's hear the answers. Clamping with a hemostat. What is the problem with clamping with a hemostat? Because there's a large pulsatile bleeding. Okay, somebody has answered. What is it? B. Kavidu Vijay Sundara. B. Yes, Kavidu, you are right. You are correct. Very good. So let us see why you are correct. Okay. So clamping with a hemostat. So why is wrong? Because there's a bleeder, you can clamp with a hemostat. So it might be also correct for some people. Why? Because there's a pulsatile bleeder, and you don't know, you can't see where the bleeding is coming from, and you will be clamping blindly. You can basically blindly see where the point and you clamp. And usually in the lower limbs, the nerves accompany these vessels. So if you blindly clamp a vessel, you can put the clamp through the nerve also. So you will prevent the bleeding, but you will destroy the nerve also. So clamping with a hemostat blindly is not a good option. Direct pressure, yes, that is the most appropriate initial step to prevent. That is true. Exploration and packing, that is the definitive management. That is not the initial step. That is a definitive. Tourniquet application. Tourniquet application is not the most appropriate initial. It is the last resort in the initial. So if the pressure doesn't apply a good hemostatic control, then yes. Otherwise, traction splint is not useful here at all. Okay, I hope you got the concept, because it's pressure first, then if it fails, tourniquet, and exploration and packing is the last resort. Clamping is not recommended blindly because of the damage that can cause to surrounding other important structures. Which of the following are done during the primary survey? So what they are asking, what are the adjuncts to the primary survey? Okay. Okay. ECG trace. What do you think? This is an MCQ, not SB. Anybody? ECG trace? Yes. If you remember the adjuncts that I have showed you earlier, ECG was part of it. Yes, because the patient might have an arrhythmia during resuscitation, and we need to detect it and treat it, because there's no point of resuscitation if there's arrhythmia going on. Imagine there's a patient with the resuscitation, patient goes in ventricular tachycardia, and we need to shock the patient. For that, we need the ECG. The ECG monitoring with the monitor is necessary. So, is it stress? Yes. It's a part of the primary survey. Blood pressure and pulse measurement. Yes, that is also true. Cervical spine pipe stabilization. Yes, definitely. It's in the A. It's the initial part. Examination of thoracolumbar spine. What do you think about this? Is it a part or not? Okay, somebody has put true, false. Okay, Kavidu has said examination of thoracolumbar spine is false. It is not false, actually. It is true, because in the D, A, B, C, D, we have to check, we have to log roll the patient. By that time, we have excluded the airway, breathing, ventilation, and the circulation. Now we are in the disability and neurological status. So in that part, that is a part of the primary survey. In disability and neurological examination, we do roll the patient and we palpate the cervical, thoracic, lumbar, and sacral spines to check whether there's tenderness, whether there's stepping, whether there's palpable fractures. Because, and then we check the anal tone and the anal tone. So examination of the thoracolumbar spine is a part of the primary survey. That is not a part of the secondary survey. Okay. How did you understand? Okay, very good. Very good. You are answering questions very rapidly. Very nice to see. Okay. And ensuring adequate airway supply, definitely it is part of it. So there's nothing to discuss about that. Okay. 35-year-old polytrauma patient was admitted to ETU. He is in respiratory distress. GCS 9 out of 15, and he's on 50% oxygen. His ABG results were pH 7.25, carbon dioxide 90 millimeters mercury, carbon dioxide pressure, partial pressure. Partial pressure of oxygen is 60 millimeters mercury. Bicarbonate is 30. Base excess is 3 millimoles per liter. What is the most appropriate management? Now, this needs you to read an ABG. So just to touch on it, when you read an ABG, first of all we should see whether it's an acidosis or alkalosis. For that, we look at the pH 7.25. Now the range is 7.35 to 7.45. That is the normal range. 7.25 means that is pH is low. When the pH is low, it is called acidosis. If the pH is high, it is called alkalosis. All right. Once you have determined this is alkalosis or acidosis, we have to check, we have to get to know whether this is a respiratory acidosis or alkalosis or metabolic alkalosis or metabolic acidosis. That is to look at that, we have to look at the partial pressures and the bicarbonate and the base excess. Okay. So now in these patients, partial pressure of carbon dioxide is 90 millimeters mercury. So the normal carbon dioxide, you will never see this much of carbon dioxide pressures in a live patient, but just understand the concept. The normal partial pressure of carbon dioxide is between, in arterial blood gas, is 40 millimeters mercury, 40 to 46. That is the range. Okay. So this is way too high. So this means there is carbon dioxide retention. So the carbon dioxide not been exhaled properly in the lung. So there's something with problem with the ventilation. Okay. And partial pressure of oxygen, it should be more than 90. It is less than 60 here. This is 60 here. So there's reduced ventilation, reduced air intake to the. So there's problem at the airway level also. Okay, so airway or breathing level. So this is a type 2 respiratory distress. Now look at the bicarbonate. The bicarbonate is 30. The normal bicarbonate level is 12 to 18. So the bicarbonate level is high side. If it's an acidosis, if it's a metabolic acidosis, the bicarbonate level will be low. But if respiratory acidosis, the bicarbonate level will be high. Okay. So based on all these information, what does this patient has? This patient has a respiratory acidosis, type 2 respiratory acidosis. So let's see what is the most appropriate management. CPAP, endotracheal intubation and ventilation, bicarbonate, mannitol, antibiotics. Or I think somebody put an answer. We'll see. Kavidu again. Kavidu, why do you think mannitol infusion? Is it you want to say B and you mistakenly sent D? There's no point of giving mannitol. Okay, mannitol infusion is given when there's intracranial hypertension. There's no point. IV antibiotics useless. Now there's metabolic acidosis. Somebody might think, okay, there's metabolic acidosis. I can give bicarbonate. Why not? So why is it wrong? First of all, the bicarbonate level is already normal, already towards high side. So what's the point of giving additional bicarbonate? And apart from it, in respiratory acidosis, we don't we in acidosis the new trend is not to give bicarbonate except for few select reasons. Those won't be asked from you. That is true for high-fi level, even not for us. That is for anesthesia, uh, not for general surgery. So there's no point of giving bicarb for us because already the bicarb level is 30. There's no point of giving additional bicarb, and for acidosis, the bicarb giving bicarb is going out of trend. It causes more harm. Okay, and then there's CPAP. CPAP is a non-invasive ventilation method. Okay, now this patient is failing to ventilate at the lung level also, at the level of the alveoli. So giving just CPAP won't improve the patient. But we need this endotracheal intubation and ventilate. That is the maximum we can do for this patient. We might not be able to elevate the problem at the ventilator level, but the best we can do for this patient is endotracheal intubation and give adequate ventilation. Okay, you understood the concept? Okay, Manuli Jayasinghe, you got the answer correct. Very good. As I said, CPAP is a non-invasive ventilation method. It doesn't have it won't give you, it will be a temporary method of, not a permanent, because there's no endotracheal intubation. So it's not going to work here because it's not a it doesn't give a permanent airway. Okay. Did you understand, Tiloka? Why CPAP is not wrong or is wrong?
Yes.
Tiloka, I hope you understood. Okay, very good, very good. Okay, let's go to the next one. Okay, true and false regarding triage. ATLS guideline should be used. This true and false. So ATLS guideline should be used to sort injury pattern. What do you think? It's true, right? That we discussed it just. This entire thing is called ATLS guideline. Okay. So children are given priority. Is it true? No, there's nothing called children. So it depends on type of casualty, mass or multiple. If it's multiple, the patients with the high life-threatening conditions are treated first. If it's a mass casualty, people who have the biggest chance of surviving are given the treatment first. So being a child is not a priority in triage in mass casualties. Okay, so that is false. True, false. Do best for each individual. No, that is totally out. So what we do is do best, not to do best for each individual, best for the individuals that have the most chance of surviving, not for each individual. Done by the most senior and experienced person. Yes, that is true. Done in daily hospital admissions. Is it done in daily hospital admissions? No, it is not done in daily hospital admission. It is used. It is done only in mass casualties or disasters. That is why it's called triage. It's only done in disasters when there's a exceptional patient load coming. For example, you must have seen in COVID. That's a disaster. We do triage in COVID, not relevant to trauma. I'm saying I'm generally triage. In COVID, it's a disaster. So at the disaster, we do triage and we get patient. That is also triage. In trauma, is a different triage. We try to sort out the patient with the most chance of survival. In COVID, what we did is we triage the patients with high risk of COVID infection and low risk of COVID infection. But here is a different triage. Okay, just to explain you the concepts. Anybody got the answers correct? You can answer. You can comment the answers. Okay. Okay. Regarding abdominal trauma, damage control surgery can reduce irreversible physiological insult. What do you think? Anybody? That is true. That is the principle of damage control surgery. Damage control surgery is done to hold the progression of injury. We don't want the compensation physiology, compensative part to go into decompensation. That's called damage control surgery. We do a surgery to prevent the patient from going into decompensation, not to do a full total reconstruction. We just try to hold the patient's prevent the patient going to decompensation. So imagine patient is basically having liver laceration and bleeding. We do a damage control surgery. And on in that surgery, we see that there is also a large bowel injury. We are not going to repair that. We might even click the two ends and drop and come out. And we only treat the liver injury and we pack it and come out. But later only we go and attend that colon injury. That is called damage control surgery. We do what necessary, only necessary at that point. We don't go and treat everything. That is to prevent the patient from going into irreversible physiological insult. That is decompensation. That is true. Anybody get that correct? Yeah, true. How you do? Very good. Interventional radiotherapy can be used as to achieve hemostasis. What do you think? Yes, it is true. I said earlier. In some instances, yes. Laparoscopy is an alternative laparotomy in stable patients. Now, this is little tricky, little advanced for you. Now, you think now the normal concept is that if laparoscopy is not for trauma, that is not true. There is a chance for laparoscopy in trauma patients, given in a context. So, if the patient is completely stable, okay, and there's no the fast is negative, and imagine there's a penetrating injury to abdomen. The fast is negative, but there is some free gas in the abdomen in the X-ray. Now you might suspect there might be a bowel injury, or there might not be because the air could be just sucked in during the stab injury. So in order to diagnose, we don't have to make a full laparotomy incision. We can go with a laparoscope and inspect the bowel. And at that point, if we detect a injury, then we can convert into laparotomy. So by that, we can avoid the laparotomy in stable patients in trauma. So there is it is an alternative, but in select context, not in every patient. It depends on lot of factors. So if I were you and I am going to the ERPM exam, this stem, I would leave it. I would not touch it because it is contraindicated. You can obviously justify your answer, but the problem is when the answers are marked, you are not there to justify. So imagine the answer is made by a old, imagine the stem is made by old surgeon who thinks that laparotomy is not an laparoscopy is not for stable patients. You might lose marks here. It's a tricky question. It's better to avoid questions like this and gain 4 marks from the other stems. So that is my advice. All right. But principle wise, laparoscopy is, yes, it has a pass. It has a place in stable patients in trauma. Okay. Did you understand the concept? That is that is my aim. Did you understand the concept? Okay. Okay. Surgical intervention is mandatory for liver laceration. Is it? No, because I said earlier grades 1, 2, 3 can be managed with in non-conservative management like angioembolization. Abdominal distension is an early sign. What do you think? I need an answer for this from somebody. Abdominal distension is an early sign. Come on, somebody need to answer this. Phones, yes. Tiloka, very good. Because abdomen can distend. So around 2 liters of blood can be collected in the abdomen, and if you consider the pelvis also, almost 3 liters of blood could collect in the abdomen without visible distension. Okay, so abdominal distension is a very late sign, and sometimes it is the last sign you see after the patient dies. So it is not an early sign. Very good. So you have understood the concepts. So 56-year-old man following a fall from a height. On admission, he is confused, slightly breathless. Respiratory rate is 24 per minute. Pulse rate is 130. Blood pressure is 80 by 50 millimeters mercury. No urine output at catheterization. He weighs 70 kg. The abdomen is tender and there is bruising on the left side. You suspect intra-abdominal bleeding. What is the likely volume of blood loss? Okay. So somebody try to answer this. So you remember that chart? You remember that chart and think what class of this is. So I need to, so only two has answered. I mean, this is a concept that everybody of you need to understand. So I would prefer it if everybody answered this question. So unlike other questions, this is a very important question. This is all these questions are past paper questions from local university final MBBS questions for the surgery MCQ. So these are questions that can come in your, these are type of questions that can come in your exam. I didn't want to ruin your past papers, therefore I didn't put past paper questions. We will discuss it in past papers. So I need all of you to answer this question because this is a type of question that usually comes in your exam. So Girindu answered, Kavindu answered, Tiloka answered. Okay, since it's 12, almost 11:40, I will answer. But I need all of you to understand this concept because it's very important. Okay. So, there's a significant tachycardia, and the pulse rate is the systolic blood pressure is 80, so it's very low, and the pulse pressure is 30. The pulse pressure is normal, but significant tachycardia, and there's no urine output, and the patient is confused, and he weighs around 70 kg. Okay, so what kind of what category is it? Class 1, 2, 3, or 4? Huh? He is in class 4 because there's no urine output. Okay, there's no urine output. Then there's significant loss of significant BP drop, and he's confused. So this is most likely in the either class 3 or class 4, more towards class 4. So class 4 is more than 40% of blood loss. So in a 70 kg, I told you that is that the measurements for 70 kg, 70 to 75 kg adult. So what do you think? It's more than 2 liters, right? More than 40%. You calculate the value and see, because out of the body weight, only two out of the body weight, 2/3 are fluid. Okay, out of the 2/3, only 1/4 is available in the sorry, wait a minute. That was I also confused that. Sorry for the confusion. So out of the 70 kg, 1/3 is solids. Okay, and the other 2/3 is liquid. So the total body water is 2/3 of the body weight. Okay, out of that body weight, uh, uh, 1/3 is extracellular fluid, and 1/3 is extracellular fluid, and 2/3 is intracellular fluid. That is cell fluid inside the cell. Okay, and out of that also, out of that 1/3, 1/4 is only the intravascular fluid. Okay, so first of all, you divide 70 by 3. Okay, and then you divide again by 3. Okay, and you then again divide by 4. Then how much will it comes to you? 70 divided by 3, by 3, by 4. So it's 1.9 liters. So 1.5 to 2 liters is true, but given this our calculation is true 1.9 liters, but given this context, it looks like class 4, and for 70 kg patient, it is almost like more than. So it's for 70 kg patient is D. So 1.5 to 2 liters. Yes, that is true. D is correct, not E. I also actually thought E, but for 70 kg patient, if you calculate it correctly, it's D, 1.5 to 2 liters. Did you understand? I think I have not mentioned about the fluid distribution in the body. So if you just can make a small note out of like our body, our entire body mass, out of that, if you divide it to 3, 1/3 and 2/3, 1/3 is fluid, 1/3 is solids. That means solid particles, and the other 2/3 is water. So 2/3 of our body mass is basically water. Okay, out of those 2/3, okay, out of those 2/3, one 1/3 is extracellular fluid, that is blood and the interstitial fluid, and 2/3 is intercellular fluid, that is fluid inside cells. Okay, okay. Out of those 1/3 of extracellular fluid, it also can divide into interstitial fluid and intravascular fluid, that is fluid inside the vessels and fluid outside the vessels, but not inside the cells. Okay, the fluid inside the cells are inside the vessels are 1/4 of that 1/3. I know this is a little bit confusing. I will send a I will try to upload a photo of it. I will upload a photo, small photo with it. So the ERP admins will send you all this photo, so you can have a look at it. So yeah, it's a little bit confusing, but the answer is D, 1.5 to 2 liters. Okay. Okay. Sorry for the dilemma there. I will send a photo explaining all of it. Okay. That is not part of the trauma, but you need to know that also. So I will send part of it because it was not part of a trauma. I didn't encompass it. I will send you all. Sorry, I'm sorry for that. Which of the following factors should be considered prior to a removal of an ICU tube? Okay, this is also a topic which you should know. This is part of the thoracic trauma module. But I will let you in a little bit of it. So when you remove an ice, you should know why who have you put it the IC tube before you removing. For example, IC tube could have been put due to a hemothorax or pneumothorax. If it's done due to a pneumothorax, yes, we have to wait until bubbling is cessation. If there's ongoing bubbling, that means then pneumothorax is not settled, or there's an existent bronchopulmonary fistula. Okay, so those are the two indications. So if there's bubbling ongoing, we can't remove the IC tube, because otherwise the pneumothorax will appear again. Re-expansion of the lung on the chest X-ray. Yes, if the lung is not re-expanding the chest X-ray, we can't remove it. Okay. Cessation of the swinging of the tube. Yes, when the lung is fully expand, the swinging. Now, when you put an IC tube, how do you know it works? You look at the swinging. If the fluid column is swinging, that is IC tube is working. But when the lung is completely expanded, the swinging will reduce, and at some point it will stop. That is an indication that either the lung has completely expanded or the tube has been blocked. So cessation of the tube is so it can be a factor that can be considered. Yes. Okay. Reduction of the pain in the chest. No, that is not an indication for removal of chest pain. Patient might be having chest pain due to other conditions. So reduction of pain is not an indication. That is false. Reducing surgical emphysema. So if the surgical emphysema has already occurred, it will take days to reduce. So just because surgical emphysema is still there, there's no point of keeping. If the lung is expanded and there's no pneumothorax, then you can remove the IC tube. You don't need to wait for the surgical emphysema to reduce. So the last two is false. The first three is true. Anybody got the answers? No. So 100. So sorry for the typo. Not 125. 25-year-old male presenting with trauma to chest and with distended neck veins and Freddy pulse with a blood pressure of 80/60. On examination, trachea was in central position. Breath sounds were normal on both sides. What is the initial management of this patient? So this is also a little bit going to thoracic trauma. So distended neck veins, Freddy pulse, and the low blood pressure is called Kussmaul's triad, and the Kussmaul's triad, and the fact that the trachea is also is central. It is not towards a tension pneumothorax. So this is a cardiac tamponade. So this clinical picture is a cardiac tamponade. So what is the initial management? It is, now we have to release the pressure in the pericardium. For that, we need to do a pericardiocentesis, but it needs the patient to take to theater. till that time, to bridge the gap, we can do a needle thoracocentesis, needle pericardiocentesis. Okay. So the answer is D, pericardiocentesis. Okay. Anybody got the answers? Correct. D. Very good. Super. 50-year-old male presenting with RTA with a penetrating injury to the right chest. He was dyspneic, pulse rate 120 beats per minute, and had encroached neck veins. On examination, left side thorax was hyperresonant and there was reduced air entry, trachea deviated to right side. What is the most likely diagnosis? Okay, what do you think this is? B. Tension pneumothorax. Yes, of course, you are correct. Tension pneumothorax. Because why? Encroached neck veins, hyperresonant chest hemothorax, reduced air entry, and trachea deviated to right side. All the typical findings of tension pneumothorax. You're absolutely correct. So, indications for thoracotomy in a patient with blunt trauma to chest. This is a little bit also going to in thoracic trauma. So 200 milliliters per hour for 3 hours. Yes, that is an indication. That is true. Persistent cardiac tamponade, definitely true. You have to intervene. Massive unilateral pulmonary contusion with hypoxia. No, you are not going to achieve anything by doing thoracotomy. It's just conservative management for pulmonary contusions. You just have to basically intubate and ventilate the patient with adequate fluid balance. Hemothorax of 1,500 milliliters of fluid at IC tube insertion. Yes, that is an indication of thoracotomy. And flail chest. Flail chest is not an indication for thoracotomy. So it's true, true, false, or true, false. Did anybody get this answers correct? I hope you guys are answering at least at home. Huh? So regarding tension pneumothorax, causes hyporesonance in the opposite side. Is it true? No, this is the ipsilateral side, not the opposite side. Okay. Causes distended neck veins. Yes, because of the mediastinal shift, the cardiac the blood coming to the heart is obstructed, so the venous side is engorged. Causes mediastinal shift to the opposite side. Yes, true. It's called mediastinal shift. Causes obstructive shock. Yes, true, because the heart cannot relax in the diastole, so the blood can't come into the heart to pump. It is confirmed by the chest X-ray. That is wrong. You don't do chest X-ray to confirm tension. It's a clinical diagnosis. So if you have the clinical suspicion, you act there and put ICT. So it's false, true, 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 false. Anybody got the answers correct? True or false regarding chest trauma? Fast scan is indicated. What do you think? Yes, in chest trauma, you can do a fast scan because you can look at the costodiaphragmatic recess and small hemothorax that might not be visible in chest X-ray. We might see in the ultrasound scan. Yes, and even chest trauma, especially in the lower side, might injure the spleen and the liver, lower rib fractures. So that can cause abdominal bleeding. So the fast scan is indicated in chest trauma. Yes. Pleural segment causes pulmonary contusion. This term is a little bit ambiguous. Pleural segment itself does not cause pulmonary contusion. Pulmonary contusion is caused by the trauma. But pulmonary contusion does cause pulmonary atelectasis. Sorry, fail segment does cause pulmonary atelectasis, not contusion. So this is a little bit ambiguous term. So because of that, if I am sitting the ERPM exam, I would leave this term B because I'm not sure what the examiner intended with this term. Fail segment causes pulmonary contusion. It's not the fail segment, it's that the trauma causes the pulmonary contusion. It's not the failed segment. It's just a different story. So failed segment is related to pulmonary contusion. Yes, that is true. Okay. So me personally, I would leave this second stem. Chest X-ray is needed for IC tube insertion. No, that is false because IC tube insertion is with clinical judgment. As I said, intention pneumothorax is a clinical judgment. If you suspect it, you insert the IC tube. You don't wait for chest X-ray. If the IC tube return is more than 200 milliliters over 3 hours in hemothorax, it's an indication for thoracotomy. Yes, we discussed it earlier. 28 gauge IC tube is used to reduce tension pneumothorax. Yes, in tension pneumothorax is just air. So we can use a smaller caliber IC tube. But in hemothorax, it's blood. When you put the IC tube, the blood can get clogged in the IC tube and it can block the IC tube. So what we need is a larger caliber IC tube in hemothorax. So in hemothorax, what we use is 32 gauge. In pneumothorax, we use 28 gauge in adults. So this is true. Now in this MCQ, our objective is to get as maximum as marks while avoiding negative marks. For that purpose, in this MCQ, by just leaving this B stem, we can easily get 4 marks. Okay. So if we go and try to mark this B segment, we don't know what the examiner has intended from the question. So we might lose additional mark. Okay. So because of that, it's best to avoid stems like this. Ambiguous stems like this is best to avoid. That also you must learn to master. You must master before going to the exam. You need to master what stems am I going to avoid, because our goal is to pass the exam here. So we know the principle. The pulmonary, lung under the failed segment can have pulmonary contusion, but that is due to the trauma, not directly because of the failed segment. The failed segment will cause pain, and that pain will cause to the patient to reduce breathing in that side. That will cause basal pulmonary atelectasis, not contusion. So this is ambiguous. Better not to try, or better to avoid stems like this. Okay, that's also something you need to know before you go to the exam. Which stems am I going to avoid? 37-year-old male following RTA is brought to the hospital. On admission, his pulse rate is 112, BP 140/90. He has multiple rib fractures on the 8th to 11th ribs. What are the possible complications? Fat embolism, not in rib fractures, that is in long bones. So it is false. Pneumonia, yes. If there's pulmonary contusion and basal atelectasis as a cause of failed rib fragment, it can cause pneumonia. That is true. IC tube insertion may be indicated. Yes, might be. There could be a new hemothorax or pneumothorax, then IC tube might be needed. That is true. Can be treated as outpatient. No, because why? Because the patient is having tachycardia. Even though the blood pressure is normal, he's having tachycardia. He could be in class 1 hemorrhagic shock. So we can't just discharge the patient. We have to observe. Need urgent fast scan. Yes, because there's a tachycardia. There could be some ongoing active bleeding. And it's the 8th to 11th rib, so it's a lower down. So it could injure if it's a left side, it could injure the spleen. If it's the right side, it could injure the liver. So the abdominal fast scan is definitely indicated. It is true. So false, true, true, false, true. Anybody got the answers correct? I hope everybody got the answers correct. Okay. Young patient presents with chest trauma following a fall from a tree. Diagnosis of left side failed chest was done. What should not be done in the first 24 hours? Bronchoscopy, left side IC tube, oxygen via face mask, thoracic epidural, IV fluids. What do you think? Left side IC tube, if there's associated hemothorax or tension pneumothorax, yes, will need. What is oxygen via face mask, definitely we need oxygen support because there could be pulmonary basal atelectasis. Supplementation. Thoracic epidural, yes, because the failed chest segment is very painful, and because of that pain, patient will tend to not breathe properly in that side. With that, there will be basal atelectasis of that side. So with that atelectasis, it could cause pneumonia. In order to prevent that, we need the patient to breathe without pain. The best analgesic to give is a thoracic epidural or intercostal block. So thoracic epidural is a analgesic mode that can be given to this patient. So that is true. IV fluids. We should give IV fluids, but there is not liberal IV fluid. We should be cautious IV fluids. If there's hemodynamic instability, yes. If there's no hemodynamic instability, then better not give IV fluids. But what should it not be done? No. If there's indication, we should give IV fluid. Because if we give too much IV fluid, what will happen? It will worsen the pulmonary contusion. Because it will cause pulmonary edema and it will worsen. So we don't need to give liberal, but if it is indicated, if there's hemodynamic instability, yes, we need to give IV fluid. So that is also something that should be done, not done. So what about bronchoscopy? Bronchoscopy we don't need to do for the failed check. There's no point of gaining by doing a bronchoscopy. So that is the wrong answer. That is the answer. Or answer is A. I think very good, Kavita, you got the answers correct. You are the answer correct. Now regarding, there was a small question that, yeah, here. Question number 8. In this question, I also got a little bit confused. I'm really sorry guys for that. So as I told earlier, I will send you the picture of how the the fluid in our body is distributed accordingly. So I think I said the answer is D, 1.5 to 2 liters. I'm sorry, I just while you are answering the questions, I just had a look, and it's actually more than 2 liters because this is class D hemorrhage. I'm really sorry for the confusion. I will explain this question again. So the patient is having tachypnea and significant tachycardia, and there's significant systolic blood pressure drop. It's almost 80, but pulse pressure is normal, and there's no urine output to the catheter. So that means there's significant hypoxia to the kidneys. Okay, and the patient is weighing 70 kg. Okay, now as I said, the fluid distribution. So out of the 70 kilograms, 2/3 is in the extracellular fluid. Okay. Body water. Okay, now we'll divide 70 by 3. Okay, and then multiplied by 2. That is 46. So 46 kilograms of fluid is there in this patient's body. Okay, that is the total fluid amount. And out of those 46 kilograms of fluid, 2/3 are within the cells. Okay, 2/3 are within the cells. That is intracellular fluid. Okay, and 1/3 is extracellular fluid. So we'll divide this 46 kilograms of fluid by 3. So that comes as 15 kilograms of fluid. Okay. Now, out of this extracellular fluid, 1/4 is in the intravascular compartment, and 3/4 are in the interstitial fluid. That means outside of the cells, but also outside of the vessels. Interstitial fluid between the cells. So this 15 cc will divide by uh, 4. So that is 4 liters. Okay. 3.8 liters. So this patient is having a blood loss of more than 40%. Okay. Then we'll make this into 40%. Right. Into 40%. So out of that 40%, so 40% of 3.8 kilograms is 1.5. Okay. So if this patient is having blood loss of class 4 category and having more than 40% blood loss, then the patient is having a blood loss of more than 1.5 liters. Okay. So the answer is then comes as D, 1.5 liters to 2 liters. Did you guys understood or not? Sorry for the confusion. I also got a little bit confused here. That's why I came back to this question and did the calculation and showed you. Anybody? If anybody understand, can you just say I understood? If anybody didn't understand, just also you also just say I didn't understand. Not a problem. This is also an important topic that might be asked in the MCQs. I know it's already May 12 o'clock, so it's not good for you to come bother you also. But I hope you understand this concept. Okay, it's all about body fluid distribution. Okay, I'll send you a photo of it. You just have a look through and you make the calculations. If you have any doubts, just contact the ERP Mastery admin. They will give you my email number. You just chat with me. I will explain to you again. Okay. So I'm really sorry for dragging out the class this long because this topic is very important. It can't be summarized into a very short segment. So that's why the class dragged in around for 3 hours. And I'm really sorry for disturbing you guys for this much time because I know you have been through entire bits of classes to the daytime also. So I am really happy that you guys stayed with me till the end of the lecture. Okay, then if you have any doubts regarding these questions, you just let the ERP master know, and they will give you my email address. You can contact me. Okay, thank you guys for staying with me for this time. Okay, then have a good night. Then I'm not going to keep you waiting for so long. Have a good night then.